Good morning, everybody. Good morning, everyone. Welcome, welcome. I can hear my voice reverberating. It's all on. Welcome, everybody. Thank you for coming. If you don't know me, my name's Paul Jennings. I have the privilege and pleasure of being the chair of Hospice UK. It's my role to welcome you this morning, to thank you all for coming. I did just wonder, actually, if you wouldn't mind, earlier on I tweeted a picture of this auditorium completely empty. So would you mind just all smiling? A bit wider. Thank you. If you don't mind, I'll tweet you later. So welcome and thank you for coming to Glasgow. It's great to be here. It's quite a long time, I confess, since I was last in this wonderful city, and I've been reminded already by our plenary speaker what a fantastic place Glasgow is and how I've wasted my entire career by not working here and working in England, so I apologise for that. Can I thank our sponsors, if I may, first of all, our gold sponsors, Towergate, who we'll be hearing from shortly with their award, Dreamscape Solutions, JDDK Architects, and Legacy of Lives. I'd like to also thank our other sponsors and our exhibitors, and can I invite you to spend some time in the exhibition hall and meet the various exhibitors and talk to them. They work hard to be here and they have interesting things to say, and some of them even have prizes, which is always a good thing to have, isn't it? I'd like to say that I've been briefed what to say, but I tend to go off brief quite often. One thing I've not been briefed to say, and I really want to say, is thank you to the Hospice UK team for setting up this conference. The amount of work that goes into this is just incredible, to get everything in place, everyone in place, virtual, hybrid, the whole thing, the branding and so on. And actually I'm told that some of our colleagues were here yesterday morning at 6 o'clock, would you believe, making sure that the carpet was laid correctly. They've really worked incredibly hard. And none of us have been helped by Avanti West Coast in our mission, have we, over this week. The presentations from the conference will all be available online in 10 days. You've been given, I think, a password with your email so you can access them, and those will all be loaded up. I have to ask you to turn your phones to silent. This is where I nervously check mine for the 14th time, and yes, it is silent, because my phone plays the red right hand quite loudly, which you will know is the theme tune of Peaky Blinders, because I'm from Birmingham, and it's very embarrassing when it goes off, so I request you to turn yours off as well. If you're watching online, you can put questions just as easily as in the hall. We're asking people to use Slido, which we used last year, and at some point there'll be some details that tell you how to log into Slido if you haven't already. I find it really helpful, actually, because Slido is essentially, it's anonymous, and some of the questions that I get are so rude, and I just know that people wouldn't have the courage to ask them if they had to stand by microphone number 3. So please use Slido, and if you're online, use the Q&A box underneath, and you will your questions will appear with the same priority as in the hall. I've been asked if I could just mention to you the ethical conundrums roundtable sessions. We've set these up for the first time this year. You'll see them in the programme. They are deliberately meant to be a safe space for us to have open and honest conversations, discussions about some of those things that maybe we find quite difficult to discuss in other settings. So we'd be interested to have people come to those, if you would, and really interested to hear your feedback from them as to whether it's something we should continue to do with next year's conference. But we just think there are some burning issues in our world that we need to have conversations about, but people can find quite difficult. They're quite challenging. People sometimes feel they need to take particular stances or positions. So these are safe spaces for us to have open and honest conversations about some of those interesting and difficult ethical dilemmas. I wanted to say also thank you to Craig Duncan, actually, and the SLT, Senior Leadership Team. because they held the fort for 9 months while we went through an interim process to find a chief executive. I'm going to introduce to you shortly, although you already know who he is. We felt it was really important that we had an inclusive process to appoint the chief executive. We wanted to take time to consult the membership through the advisory council. The chief executive is your chief executive as well as our chief executive. So the process took quite a while, and I'm really, really proud of the team and the way they kept things stable and running, still on the back end of COVID, if you remember, while we went through that process. I was reflecting on the way up here that it's almost, I think, exactly 3 years since we first heard in the world of public health that something was going on in China. And since then, we have had unprecedented use of the word unprecedented. Everything has been unprecedented since then. We had a worldwide pandemic. We had a vaccine that was developed in what seemed like a lightning flash. We went from having soap and oxygen as our only weapons against COVID to a whole range of treatments, to a place where we are learning now to live with it. And it's on the back of that, war in Europe, cost of living crisis, a whole series of things that we have to cope with. And Toby will talk about some of that. But in the midst of life, as I say, we're also in the midst of death. And the work that you are doing, the work that you're doing individually with people who are moving to the end of life, the work that we're doing as a movement to try to get end of life taken as seriously as the start of life is incredibly important. And I thank everybody in this room for their work and their part and their participation in that. So without further ado, I did actually threaten him with doing a ring walk and coming down the aisle, but he decided he wouldn't do that. And we're not allowed to play Eye of the Tiger either, apparently, because we're being live streamed. But without further ado, can I introduce our new Chief Executive, Toby Porter.
Thank you very much, and welcome. On behalf of everybody at the whole team at Hospice UK, may I give you the warmest of welcomes to this year's national conference, Finding a Way Forward. Thanks so much for taking time from your busy schedules to be with us these next 3 days. It's wonderful for us, and of course I hope for all of you to have such a large gathering of the country's hospice community. And I'd like to extend my gratitude and welcome to our sponsors, our exhibitors, and our conference paper authors and poster bearers as well, whose work you'll see in the halls. I'd also like to say a personal thank you to Kirkwood Hospice in Huddersfield, if they're here, because I bought my Jaeger suit for £12 from their online shop. And support your local hospice, you know what bargains are to be had. Because I realised I hadn't got any suits after the last few years. So we're delighted to be here in Glasgow, first time actually, and to have guests and speakers from those, not just our Scottish hospice colleagues, but those designing and delivering the new Scottish Government strategy on palliative and end-of-life care. For those of you getting to grips with the ICS systems and rollouts and meetings and boards in England, you have a chance to learn from 6 years of experience here in Scotland, where integration of health and social care authorities and services has been in place. Scotland is also the focus and really the front line for, in the UK, for one of the most controversial issues facing our sector and society at large, with the proposed assisted dying for terminally ill adults bill lodged at the Scottish Parliament in September and expected to be voted upon in 2023. You can listen or contribute to discussions related to this topic at our ethical conundrum meeting tomorrow morning. So we welcome delegates from all 4 nations. There's so much to learn and to share between colleagues from the different countries. And it's a proud and happy moment for me personally, as Paul mentioned, because I welcome you to this conference for the first time as the CEO of Hospice UK. I started my role in the end of the second week in September, which to date is only 2 weeks after Liz Truss started her new role. So I kind of feel the fact that I'm here at all is a success indicator of my first 2.5 months. It's been great to get to know the Hospice UK team and already meeting a good few of you and your teams. You make me all feel very welcome. Thank you. The work we do as a hospice sector couldn't be closer to my heart. As many of you know, it was my privilege to work for 6 years as Chief Executive with Acorns Children's Hospice, during which we faced and overcame a succession, really, of very serious challenges: financial, service cuts, job cuts, coming within a whisker of closing one of our 3 children's hospices, actually the one in the most deprived geography. Then the COVID pandemic, then higher than normal clinical vacancy rates. So I come into this role with the eyes of a hospice CEO, and certainly under no illusions and of the daily challenges you and your teams face. Yet for all of the challenges, I still think that working in a hospice often feels like the best job in the world, due to the people you meet, your clients, their families, your workforce, your volunteers, those whose compassion and generosity in the community literally keep the lights on. You all do incredible work, and our hope is that we at Hospice UK can give you something back in the next few days. And so you return to your workplaces energized with some new friends and networks in the community and inspired from being here. So 10 years ago, last month, some of you will remember the Commission for Hospice, the Commission into the Future of Hospice Care published their final report. And in her foreword, Dame Claire Tickell, who chaired the commission, issued our sector a challenge. Hospices will need to keep an unrelenting focus on the needs of all those who live with life-shortening illness, on their families, on their carers, and be brave in their response to these needs. Well, this is the first conference where we would hopefully all agree that the worst of the COVID-19 pandemic for society is long behind us. So please allow me to congratulate, but also to thank you and your teams for your bravery and for that unrelenting focus on your patients during those awful times. Despite serious risks to themselves and their loved ones, your teams found ways to support your patients and your communities and keep your doors open every day of the pandemic. As a sector, hospices supported the NHS and the nation. Mostly the hospice sector was the only sector in the UK health and social care system that allowed family members to be with their loved ones at the moment of death, which I think is something of incredible importance and positive divergence to the practice as a whole. Continued donations to local hospice charities to support the most vulnerable were a powerful expression of the compassion and unity at the heart of most local communities and an antidote to the fear, polarization and division that stalk us. And while none of us would ever want to experience this again, we've arguably came out a stronger and more respected sector with a publicly acknowledged mandate to educate and lead the wider health and social care sector in palliative care. You're the experts. Your approach epitomizes what every person in the UK should have at the end of their life: true choice, support for them, their families and their loved ones, excellent clinical and nursing care, alongside compassionate bereavement support. We all believe in the fundamental right to a good death, but it's still the case that 1 in 4 people in the UK are unable to access adequate end-of-life care. The recent passage of the amendment to the Health and Social Care Act promises a country where good end-of-life is available and a right for all. And our community played a key role in coming together to advocate for and secure this legislation. But now we need to hold the duty bearers to account for turning this right into a reality. Our vision at Hospice UK is for that hospice care for every person in need, So there's much more we all must do. We must find a way forward. We must ensure that hospice care can reach everyone in our country, no matter where it's delivered and by whom. We must all unite behind the goal of changing end-of-life care for everyone for the better. People need and deserve better in this country. So expanding hospice care is no easy task in the best of times, and these are far from that. Instead of the calm and restorative post-pandemic recovery period that we all dreamed about for 2 years would be there for our teams and our organisations, and which they so deserved. Instead, hospices and others involved in the planning and delivery of end-of-life care face a new set of present and really very serious challenges. Firstly, our guiding star and whole ethos of hospice care is a total focus on the patient. But what does that mean at a time when the current state of our wider UK health and social care system is such a huge concern? To quote again from the 2013 Commission report, as the environment of care threatens to fail too many and too often, hospices will need to unite in their thinking and develop a strong voice individually and collectively. That's obviously more relevant than ever today. I know everyone here will be alarmed as professionals, but also as citizens, by the evidence of demand so obviously exceeding capacity wherever you care to look across our health and social care system, in our community services, our hospitals, our care homes, and even in our ambulances. What do phrases we value and use, such as patient-centred care or the need for an all-system approach, mean at times like this? What should and what can we try and do as an independent hospice sector to try and help? And of course, we're not immune from some of these challenges ourselves. The cost of living crisis affecting everybody in and associated with the hospice sector, the children and adults that use our service, their loved ones, our staff and volunteers, rising costs and falling donations, also bringing obvious jeopardy to our charity business models. At Hospice UK, we've listened to our member hospices when you said you wanted us to speak early and forcefully about the potential impact for hospices of these cost of living and energy increases. Working with some of you, we've got some compelling and hard-hitting stories out into the mainstream national media over the last few months, including major items on Channel 5, BBC Breakfast, and national newspapers. Hopefully that would have produced a conducive backdrop for you then to do your local media and have your discussions with your local commissioners and supporters. We're also working directly with senior civil servants and politicians on how hospices might be supported directly with energy costs after the end of the period covered by the current business price cap. We'll continue to do what we can do for you in this space, making sure that people understand what good end of life should be, what might be at risk, and why proper and predictable statutory funding remains so important to the long-term stability of our sector and of our services. Workforce probably is and probably will remain the most challenging issue of all for the hospice sector over my time as Chief Executive. You can join sessions focusing on this specifically at the conference. And we believe that every hospice team has something to contribute through experiences and ideas about how we continue to attract and retain the people we need to deliver and plan our services now and into the future. We know our people are concerned with pay as they struggle themselves with the cost of living crisis. But pay and conditions are just one of the priorities those working and volunteering with hospices are raising. Others include a focus on values and behaviours, promoting positive, healthy organisational culture, putting in place inspirational and responsive leadership, as well as stronger development of clinical career pathways, education networks, a focus on supply, recruitment, retention. Our collective call for action, each and every one of us, is to be enthusiastic and passionate public advocates for what a career in palliative care can be in our local communities and nationally, while doing what we can to make our own organisations the best possible place to work. At this conference, you'll get the opportunity to share experiences of working with the new integrated care boards with your fellow professionals and to answer key questions. What impact does your input, does your engagement have? Do you truly feel that you are able to contribute expertise and technical knowledge to making the whole system work better? As individual hospices, is the process helping you to forge or see the potential for new partnerships and collaborative working? Are you seeing opportunities for new funding coming out of the discussions? Most importantly, does the process make you feel optimistic that this will genuinely result in better end-of-life care and palliative services in your region in the future? I hope this conference will encourage you to think about how we can work together. Hospices across the UK are now an integral part of their health and social care system, probably better known and better respected than any point previously because of the role you all played in the pandemic. The door is open for you and your teams to bring your expertise and influence to bear to provide good end-of-life care for members of your local community who until now you've not been able to reach directly. And if I can make a final quote from the Commission into the Future of Hospice Care's report from 10 years ago. It is through our place in this wider system that we will find ways to deliver services to populations rather than reaching only those individuals who find their way to us. Our commitment to the idea that everybody get the care they deserve when illness can no longer be cured has a significant implication. Every hospice that welcomes this aspiration must also accept the consequent obligation to consider how best to use their resources as part of the system of care that will need to be deployed. To obtain change on the scale required means working in partnerships with each other and with providers of health and social care. So we gather here in Glasgow, the worst of the pandemic behind us, maybe the worst of the cost of living and health and social care crisis ahead of us. Of course it feels challenging, but we will find that way forward. Hospice care is a sector, but it's also a calling. Cicely Saunders said that we can relieve suffering if we put our minds to it. So our duty now as a hospice sector is to put our minds towards finding a way forward for hospice and end-of-life care in the world, not as we would like it to be, but as we find it here now in 2022. Thank you and enjoy the conference.
So, as you will know, we have a number of awards to make during the conference. They're spread evenly throughout, so we get lots of opportunities to celebrate. And our first award is going to be given now. It's given by Towergate. And it's my pleasure to introduce Harpreet Sahota. There he is. Harpreet Sahota is going to make this first award on behalf of Towergate. Thank you, Harpreet.
Thank you. Good morning, everyone, and very warm welcome to all of you here and online. The Hospice UK Awards are a special way of celebrating the incredible work undertaken by hospices and the massive amount of difference you make to hospice and end-of-life care across the UK. Towergate are delighted to support the award for Hospice Team of the Year because of the incredible work you've done during the pandemic and you do on a day-to-day basis in end-of-life care, and the stepped-up work you've done during the pandemic in helping those in the social world in regards to step-down care for hospitals and everything we've done around that. And we're very, very delighted to help there. In regards to the Hospice Team of the Year award, so without further ado, I'd like to announce Towergate Hospice Team of the Year, and the winner is the Family Support Team at St Columbia's Hospice, and the award has been accepted by Craig Hutchinson.
And now, ladies and gentlemen, it's my pleasure to introduce our first plenary speaker of the conference. We're delighted to have with us Jason Leach, CBE, National Clinical Director for Health and Social Care in Scotland. We've already had a quick conversation this morning. I'm sure Jason's going to have lots of excitement. I'm not going to read his CV out. The guy's just brilliant, isn't he? Okay, read it for yourself. Jason, come and join us. We're all mic'd up. You've got to wonder about the stage, aren't you?
I'm ready.
Fantastic. Brilliant.
Welcome, everybody. Welcome to the finest city in the world. And we only give prizes to Scots. I don't know if that had been cleared. So those of you who are from the other three countries nominated, you can basically forget it. So everybody's winning prize. So no, you're very welcome. Thank you for coming, and thank you for having me. This is a very civilized conference. It starts at 10 o'clock and lunch is at 12. I could get used to this kind of conference. This is ideal. In fact, the first speaker of the day is standing between you and lunch. That's the kind of conference I quite like. So I'll endeavour not to keep you too long. Our plan is to talk for a little while about lessons over the last 2 or 3 years from my perspective, because I'm your speaker. If you don't like them, then you can have some of your own. You'll have lost 45 minutes of your life, perhaps. And then I'm happy to take questions, and one of my colleagues over here will lead it. But the first thing I want to do is to patronise you. And many of you won't know. Where are the Scots in the room? Oh, there are some. So, first of all, I apologise for being on your telly every day for 2.5 years. I'm sorry. OK? Your granny, though, thinks I'm great. You don't. I understand that. But all the grandmothers in Scotland absolutely love me. So all the over 75s want photographs. So I'll be here at the end. If you want a picture for your granny, then I'm entirely happy to do that. The most common thing that happens to me is young people come up to me, young people like under 50, say, "Are you Jason?" I said, "Yeah, I am. Thanks for saying hello." And they say, "My granny thinks you're great." I said, "OK, do you want a picture?" "Yeah, I would love a picture." I said, "It's not for you though, is it? It's for your granny." Yep. Small children imitate me and grannies love me. I'll take it though, if we've protected anybody. So the Scots in the room, I apologise. The other 3 countries in the room have absolutely no idea why I've asked this guy to speak at your conference, because they don't know they've absolutely no idea who I am. So it's a complete mystery to them. The patronising piece at the beginning, though, is to genuinely and sincerely thank you for the work you've done in the last 3 years. Now, I've been involved with hospices, particularly in Scotland, the Airdrie Hospice, in particular St Andrew's Hospice, and the Children's Hospice movement across Scotland for a number of years. And I've had policy responsibility for hospice care and hospice funding in the government. But my heart is inside hospices. I've had family members live, die, and work inside your institutions. And during these 3 years, you've stepped up to another new environment. And I can't imagine, and this is a slightly odd sentence, but I can't imagine a once-in-100-year infectious disease pandemic without a hospice movement. Imagine how much worse it would have been for families and carers and others without you guys doing what you do, and those you represent, who, of course, I presume there are some hospices open today, are there? Are there other people still, there's people still working that you've left behind who didn't get a trip to Scotland. So thank you very much for everything you've done. It's genuinely appreciated. So this is Scotland. I thought we might do a little brief tourist introduction. Does anybody know where this is? It's the Glenfinnan Viaduct. That is Loch Finnan in the background. And, but those of you not from Scotland, perhaps, don't know it as the Glenfinnan Viaduct. You know it as the Harry Potter Bridge. So we're building a visitor centre here to fleece money from Americans and sell them Harry Potter-shaped whiskey bottles with shit whiskey in them to make money to build schools and libraries. It's a fantastic method of tourism, and here's the news, it works. So we are actually building a visitor centre because so many people were coming to take pictures of it that it was getting ruined. So we're building a visitor centre to sell keyrings and Giffen Droff, whatever they're called, capes and stuff. So this is what Scotland looks like on the 2 days a year it's not pissing with rain. But it's an absolutely beautiful country. It's genuinely beautiful. And I hope you get a chance when you're here, if you're visiting, to spend a bit of time don't miss the lectures, don't miss the exhibition hall, don't miss the lunch. Leave now for 40 minutes. No, please do see a little bit of the city and the country if you can. The hop-on, hop-off bus has a stop right here. So you can get it to Glasgow Green, you can get it to the Kelvin Grove Art Gallery, you can walk to Kelvin Grove Art Gallery and see one of the finest Dali paintings you ever see in your life. So there's lots to see and do, and I hope you will do that. But I'm afraid the reality of Scotland is not all Loch Finnan and beautiful green space. This is an 18-month-old boy. He will almost certainly have seen violence. He probably from an addicted household. His house will be damp. He'll have no green space to ride his bike. His healthcare access, although free at the point of delivery, will be much worse than his cousin 4 miles up the road. He will die 25 years younger than his mates 4 miles away. Glasgow is a completely unique city in the Western world. In 4 miles, there's a 20 to 25-year life expectancy difference. It's astonishing. Absolutely astonishing. If you take his blood cortisol levels today, he will be chronically stressed at 18 months. He won't know. He'll just be scared. He'll just live scared. And his pal in Bearsden, just 4 miles northwest, if you take his blood cortisol levels, they'll be normal. He'll have his heart attack and stroke at 85, and he'll probably get hospice care. This young man will have his heart and stroke attack at 40, and probably won't get hospice care. We have some of the most deep-seated post-industrial inequalities in the world, in the city you're sitting in. Nobody wants to be called something in public health, so they know if they use your city to name something, you know you're in trouble. So they call it the Glasgow effect. That's not something we should be proud of. But people come and study Glasgow because of that. This is part of how we're trying to fix it. So this is the Scottish National Health Service. So if you're visiting, including my 2 colleagues at the table here, you are forbidden from ever saying the NHS ever again in your whole lives. There are 4. They are entirely different. The terms and conditions of the workers are different. The organisational paths are different. We don't have integrated care boards. We've had integrated care systems since 2016. So we at Wales, again, entirely different. Northern Ireland, well, nobody's entirely sure, but there's a National Health Service, but there's no government. So it's a little bit tricky. But this is ours. 13, depends how you count the money, 13 to 19 billion, 3 regions, 14 health boards, all of which have a different tartan from space. I'm not sure if you knew. This is what Scotland looks like from the Artemis probe. So each of the tartans is a different health board, and inside that health board is the whole of health and social care. So I can't take you to the chief executive of Glasgow Royal Infirmary. That person doesn't exist. There isn't a chief executive of Glasgow Royal Infirmary. There's a chief executive of the population of Greater Glasgow and Clyde. You see the difference? So they happen to have hospitals, and they happen to have primary care, and they happen to have public health and dentistry and everything else, but there's no chief executive of the individual hospital. We have no trusts. We had trusts for about an hour and a half and realised it was a bad idea and got rid of them overnight. But we also have huge differences in the scale of what we're trying to do. So you're in Glasgow, 1.5 million people, 4 massive hospitals, the biggest new build in 20 years across Europe, 10,000 staff. It's called if you ask a taxi driver to take you to the Death Star, that's where they'll take you. Because it's a big cross from above, and the taxi drivers call it the Death Star. I'm not sure we should be proud of that, but it's where they'll take you. So we have that. Urban Manchester, Birmingham, Liverpool looks the same. But then we have Shetland. You see it top right? It's illegal in Scotland now to show Shetland in a wee box. You remember the old maps when Shetland was in a wee box? You get to jail for that now. So that's Shetland where it should be, closer to Norway than it is to Edinburgh. And if the Norwegians want to provide the healthcare there, I'd be very grateful. 19,000 people on a windswept island in the middle of nowhere who all get sick. So our only chance is fixed-wing aircrafts. The ferries take a day to get there, if they go. There's been no ferry to Shetland in the last 3 days. We haven't been able to get a ferry to Shetland for 72 hours because of the weather. So you can see the challenges of trying to provide healthcare on those environments. And now let's think about what hospice care looks like in these islands and mainland of Scotland. Hugely challenging. Barra, over here, smallest island that we have a hospital on. We've got a 3-bed hospital on Barra. I was just there. You land on the beach. It's the only scheduled flight in Europe that lands and takes off from the sand with Loganair, and there's a 3-bedded hospital there. So think about trying to provide end-of-life care in those environments. So let's think about, that was your introduction to Scotland, and let's now think about lessons. I think transferable lessons that I've learned from the pandemic, but let's see if they apply to you. So these are my 3 lessons, and then we're going to do them in order. They get a little bit shorter as time passes, so you don't have to worry if I'm too long on the first one, I promise. So my first is to understand the problem you face. So it sounds awfully straightforward, but I think we often misunderstand the challenge we're faced with, and we try and do too much. We try and manage up or manage down, and we can't. We can only optimize the piece of the puzzle we're given. So don't try and fix everybody else's problem. You're not the Chief Executive of Hospice UK. He is. So that's his problem. He needs to optimize that bit. You're not the Chief Exec of the thing you're running, or maybe you are. So optimize the bit you're in charge of. So in February 2020, I was the National Clinical Director of the health system here. So in England, I'm the closest you've got to Steve Powis, who's your NHS Medical Director in England. And I was helping run a big piece of the puzzle: safety, quality, cancer, palliative and end-of-life care from a policy perspective. I was a dentist and then a head and neck surgeon for 20 years, just in the hospitals in this part of the world. And then Wuhan happened, and somebody phoned and said, there's this infectious disease, and we get 30,000 of these a year, and we ignore them, and we think there's nothing to it. The WHO look at 30 of them a year, and occasionally they send us a little email that says, maybe this one looks like something, and we think, yeah, you tell us that all the time. It comes to nothing. Well, this time it did, and it did in a big way. Northern Italy was probably our first real warning, where we saw, if you remember on the news, you remember the people dying outside intensive care units because there was no beds. Remember field hospitals in car parks in Northern Italy. And then Northern Italy took all the middle-class skiers from Scotland and gave them COVID, and they all came home to Scotland. Unbeknown, of course, to them and to us. And it was seeded into our population just like it was seeded into every other population in the world. Our response looks a little bit like this. Now, this is a little bit retrospective, and we didn't come up with the framing for a few weeks, because in February, nobody knew what the heck it was. But this is where we ended up. So this is trying to understand the actual problem. And the complexity of a pandemic response, unfortunately, is much harder than just harm number one. Harm number one is the Chief Medical Officer, the Chief Nurse, and me. We are the leads for harm number one, which is COVID harm. So COVID harm is the number of people who have died and suffered miserably from this single disease. So we understand that. We kind of understand how many people have had it, roughly 615 million positive tests across the world, about 6.5 million deaths in the official UN figures. That's death certificate with COVID written on it. But remember, Somalia has no death certificates. Ethiopia has very bad death certification. Canada, America don't have, you get the idea. That data is hard to find. So the best estimate is a recent Lancet and Economist article that says, in short, 18 million are dead. So they took excess deaths for the previous 5 years, compared it with excess deaths of 2020 and 2021, and subtracted one from the other, and you get 18 million. So care, everything else should have been the same for those 2-year periods, but 18 million are dead of an infectious agent. It's complete and utter misery. There are no winners here. People in this room will have lost relatives. Some of you in this room will have long COVID. You'll have pals and relatives with chronic disease as a result of this infection, and we do not know why, and we don't know how to fix it yet. We will learn, and we will get better at it, but this virus didn't exist 3 years ago. So that's why it's so new. Think about how little we know even about some of the viruses we've had for decades. So harm number one, COVID harm. But now imagine you're Boris Johnson, terrifying, or Nicola Sturgeon, or Emmanuel Macron, or Olaf Scholz, and you're in a room, irrespective of what you think of their politics or them as human beings, you're in the room, you're at the seat of the head of the table, And I come in, or the punter who does my job comes in and says, right, here's the deal. There's a pandemic. Okay, we want to shut the country. Right, I'm not doing that. No, you've got to do that. You've got to shut the country. Put everybody in their houses. I don't care if you're in Detroit or Liverpool or Paris, you're going to put everybody in their houses. Okay, I'm Swedish. Well, you don't have to. That's not actually true. They did. They're just so nice in Sweden, they didn't have to make it the law. That's the difference in Sweden. Sweden just did as it was told. You imagine Scots doing as if we'd said, ah, you're fine, do it if you like. What? I can go to the nightclub if I want to go. Oh, I think I'll just go. The Swedes, we told the Swedish people said, don't go to the nightclub, but I can go if I want. Yes, you can go if you want, but don't go. Okay, I won't go. What kind of society is that? It's weird. So, pretty much every country in the world shuts itself down. But here's the problem. Shutting causes 3 further buckets of harm. So you reduce harm number 1 because you get less death and less infection. But suddenly, because you stop cancer screening for 3 months, because you have to move all your workers in to deal with harm number 1, you've suddenly missed breast cancers and bowel screening and everything else, and cervical screening that you all know we've had to stop doing. We stopped cancer screening. I remember the day we gave the advice to stop cancer screening. Probably apart from the discharge of patients from hospital to care homes, probably the toughest piece of advice I've had to give during the whole 3-year period. So there's loads of harm 2 challenges. I'll show you a couple in a minute. Harm 3 is social harm. Those of you who watch BBC Breakfast or are Scottish will know Linda Bald. Linda Bald, the finest COVID communicator, I would argue, by some way. She was in charge of harm 3 in the meetings. Harm 3 is loneliness of the elderly, dying on your own, education of our young people being stopped, all of the social things that the response did. Now, you don't want to be in Sturgeon's Seat anymore, do you? It's now got a little bit more complicated. And then the 4th harm is a guy called Gary Gillespie, who's Scotland's chief economist. You wouldn't put him on the radio phone-in, but he's a genius. He's the economist guy. And he says to Nicola Sturgeon, he says, OK, do what Jason says. That's good. Jason says, shut the schools, shut the schools. He says, shut the nightclubs, shut the nightclubs. Great. But here's what that'll do. Here's what that'll do to employment. Here's what that'll do to GDP. Here's what that'll do to business growth. And people will lose their businesses, and you'll have mental... You get the idea. So this is a Rubik's Cube. This is not a binary choice. It's not shut the country, don't shut the country. It's complexity layered on complexity. It's impossible. There's no folder on the wall that says, let's take the pandemic folder and decide what to do next. These conversations were terrible, really hard. And remember, at the beginning, the consensus scientific view was no vaccine for a decade. That was the consensus scientific view. You'll not get a vaccine for at least 10 years, if you're lucky. You might not get one at all. So the decisions at the beginning were all about trying to protect us from harm number 1, but at the same time limit harm number 2, 3, and 4. And that's what every country did. This is our framework. People did it slightly differently. So this is harm number 2, planned and emergency care. So top line is emergency care, bottom line is planned admissions. We're still not back to the normal number of planned admissions, which means you're adding to the waiting list every day. Now, you always do that, but supply and demand is now out of kilter. So supply and demand is now meaning the time you are waiting is increasing. For every month we didn't do elective orthopaedics across Scotland, we add 6 months to the waiting times. For every month we don't do elective orthopaedics, we add 6 months to the waiting times. Some people are now waiting over 2 years. We're back in the good old days when I was a boy. Some people in this room look old enough to remember it. When I was a proper surgeon, and we used to have an acronym on our theatre lists that said died on waiting list. Died on waiting list. I mean, that had gone, but it's back. Harm number 3, this is just one example. This is kids' absence from school. Dark blue is normal absence, off for a funeral, off for the flu, off because I fell off my skateboard. Light blue is COVID. So light blue is completely new kids off school, even when the schools are open. And remember, the schools were shut for a prolonged period. My wife's a teacher. She will tell you that she's an English as an additional language teacher for asylum seekers and refugees. So she will tell you that if your solution to the Eritrean immigrant population to teach them English is laptops from her dining room table, you can go and, I can't tell you what she would actually say to you, but it doesn't work. That is not the solution to teach the Pole, Eritrean and Ukrainian populations English. And then this is harm 4, economic harm. So this is crisis grants in Scottish social work. So you come, you apply for food on the table, clothes on your kids. It's a really high bar to get a crisis grant from social work, but it doubled during the COVID pandemic. The number of people seeking those grants doubled. That's just, I could show you GDP, I could show you employment, I could show you business loss, I could show you the restaurants that went bust in Scotland and Glasgow, but are now recovering. I could show you the soft play. Soft play, honestly, it brings me out in a cold sweat. I think we should have kept them shut forever. I have no children. It appears they're liked by parents. They are infectious cesspits. What on earth are you doing with your children in these ball pits? They come up holding snot from other children. But the other news is that it turns out, I don't know this for sure, I think they're run by money laundering gangsters. Because they were vitriolic. They were the toughest crowd of any industry. I spoke to every industry in the country repeatedly. Faith groups, nightclubs, the hospitality, hotels. Oh my word, soft play were hard. Flipping heck, there's only about 10 of them in the country. So number 1 is understand your problem. And unfortunately, when you lift the rock, it's usually more complex and complicated than you imagined. And actually, sitting on the sidelines, criticizing your leader or criticizing those below you are actually, when you look, it's probably harder than it looks. I'm not asking you to feel sorry for the politicians, but I'm glad I wasn't in the decision-making seat. I'm glad I was only an advisor to those decision-makers. So that might be crippling, though. So what might, I mean, one of the responses to that is just to stay under the duvet and not move, because flipping heck, it's all too hard. So that takes me to lesson number 2. And lesson number 2 is to lead, to step up. I don't care where you are or what you do, but there is something in your piece of the puzzle that you can do. There was I worked in America for an organization called the Institute for Healthcare Improvement, IHI. And they are the global leaders in systems improvement in health and social care. So they're the people who came up with the healthcare safety bundles, the infection stuff that Scotland did. I'll show you a little bit of it later on if we've got time, although I'm telling too many stories, I might not get to it. Unless you want to miss your lunch, because lunch is kind of early. No, I'm joking. So one of the things IHI did was they sent the associate medical director for Mayo Clinic. Mayo Clinic's considered to be, by many, the finest health system in the world. It's fully private in America. There's a grand piano in the front hall. But anyway, it's proper high-end, and it's really good. And Steve, who's the medical director, is a lovely man. So he took some time off, and he went around the world looking at high-performing health systems. But his exam question was different from the usual exam question. It wasn't, how do the leaders do this? What's the organogram? How do they organize themselves? How is it funded? It was, how do individual leaders behave? That was his exam question. You got it? So he also wrote a thing about how you should organize your thing. But the piece that's really interesting and new is how do the leaders behave inside high-performing health systems? And he went to NHS Scotland, he went to pieces of NHS England, not to the whole thing. He went to Jönköping in Sweden, he went to the Alaskan health system, which is by any measure probably the best health system in the world, all over the world. Singapore, okay. So let's go past that. I was going to tell a joke there, but let's go to here. So these are the high-impact leadership behaviors which he discovered, or he codified. He thought, and they're really simple, but they're worthy of a little bit of thought. And remember, they're about you. You can't direct these to somebody else. You can't say, well, the chief exec's not behaving like that. That's not the point. That's up to the nurse director to behave like the nurse director. If you are the band 5 in the hospice on a night shift, these apply to you just as they apply to the nurse director of a whole hospice system. So he saw these individual human behaviors in the leaders. So the first was person-centered care. I mean, can I skip this one for you guys? I mean, surely. This is you. This is your bread. This is what you do. This is what it's about. You might substitute family for person or whatever, but you get the idea. It's about those we serve, making sure they are in the centre of every decision that we make and do. This is a nurse in Kirkcaldy in Fife when I was allowed back out to visit again. And she was a big advocate of the What Matters to You movement. You might have seen it in Scotland. Norway started it, and now it has spread around the world. And it's just a simple, it can be above the bed, it can be in the conversation on admission, it can be in the hospice front hall, be anywhere you like. But it's just a really simple mechanism for asking patients and kind of ensuring we ask patients and families what it is that matters to them. And it's rarely chemotherapy. They rarely say chemotherapy. They usually say Rangers, or Celtic, or steak pie, or my granny, or my grandkids, or some yoghurt. My dog often comes up. Xboxes for anybody under 20. So it's just a way of thinking about it. This is another visit. This was the new health secretary. So if you imagine your job is hard, imagine in the middle of a pandemic, the First Minister of the country approaches you and says, I'd like you to be the health secretary. What? I'm quite happy being the justice secretary. Yeah, it's fine, it's good. You'll love it. Nice people. But it's a pandemic, First Minister. You'll be fine. The last one lasted a year. You'll do at least a year. It's fine. So this is Hamza Yusuf, who's Scotland's present health secretary. And we're wandering around a hospital. So the second one is frontline engagement. If you're not in the front line, you can't understand what it is. And the front line isn't the caricatured front line. It could be the boardroom. If you haven't been in these tricky board meetings, that could be your front line. Or it could be more conventionally, where the patient and family meet the service. In Toyota, if you ever get the chance to go to a Toyota factory, you should do it. It's an astonishing visit to go on. In Toyota, at the production line, everywhere in the world, there are yellow footprints drawn on the floor. And if you're a manager and you want to go talk to the workers, or you want to have the quarterly meeting with the worker, whatever, you have to stand in the yellow footprints for an hour before you're allowed to speak. You get it? You've got to stand in the front line and understand the production line before you can say, mate, you're not working fast enough, or you're not being nice. Stand here, then tell me that I'm not going fast enough, because it turns out the spanner doesn't work, because the spanner's a bit rubbish. So if you get me a decent spanner, you get the idea. Imagine if we forced every health and social care manager in the world to walk and be in the front line for an hour before they had a meeting about us. That would change the dialogue a little bit, wouldn't it? Now, you can't just give it to other people, though. This is about you and me. So we've got to be in whatever that front line happens to be. So if you're not in community hospice and you're thinking, what are these people are not working very hard, why am I? Well, why don't you spend a day in the community hospice and work out what it feels like? Or, this is a little bit of a dodgy suggestion, if you're irritated by the politicians, why don't you phone one of them and ask them to shadow them for a day and go to their constituency surgery on a Friday and just sit at the back and watch what your local politician does for a living for 8 hours. And I guarantee you'll think differently about that politician and the job they're doing than before you went in. So walk in the shoes of those who are in the front line. The third was, I'm afraid, quite dull, but hard. It was relentless focus. It is constant rhythm. It's just, this is hard, and it's hard every day, and we're going to get up again, and we're going to do it again, and we're going to do it again. But what about the measurement? We haven't got them. Well, we're going to try again. And it's really tough. But he saw that in the leaders of the institutions who he went to see, that they didn't tire. They just kept going, and they tried to make it better every day. The chief exec of Jönköping County in Sweden is a really dear friend of mine, and they've got some of the best outcomes in the world. They run a system for about 250,000 people in eastern Sweden. And I said, how did you do this? How did you manage this? It's just incredible. And he said, in Swedish, of course, he said, we just did everything. I thought, that's not helpful. We just did everything. Fourth is tell the truth. So fourth is be completely transparent with patients, families, the media, everybody. Just get it out there. So this was quite early in the pandemic when FM and I were talking to, in Scotland we have a thing called Young Scot. Every young person in Scotland gets a card, gets them money off travel, gets them collecting coffee vouchers, but it also as a kind of club, a thing, so that it's got our best sexual health website in the country. It's got the best advice for debt. So it's a great way for FM and I to talk to young people. So that's what we were doing. We were doing a live Q&A with young people, asking each other the questions that they were sending in. So we did a huge amount of this. A lot of the media stuff you saw on the telly was just the tip of an iceberg of a lot of invisible media that we did with stakeholder groups, with faith groups, with young people, with gypsy traveller communities. So we tried as much as we could to be out there, whether they liked it or not, and just tell the truth. We had digital dashboards, we had analysis. You could look up in Scotland the postcode you lived in and find the number of positive cases. You get the idea. So whatever your piece of the puzzle is, Steve, when he went round, found transparency. And then the final piece of these 5 is a made-up American word, because he's American. It was boundarylessness. And I don't need to tell you this either, but this is working across that system. So you can't do hospice care without thinking about families, without thinking about the education service or the third sector or justice or whatever. And COVID was exactly the same. There's no way we could have done vaccination without Glasgow Central Mosque, which is just down there. It became our biggest vaccination centre. I remember the day we asked them, do you think you could maybe do vaccines? We had stopped our worship services. They weren't really speaking to us. And we said, look, we really need a vaccine centre in the southeast of the city. Is there any way you could do it? And they're still open. A year and a half later, still doing more vaccines than anybody else in the country, in their mosque. So you have to work across natural and significant boundaries if you're going to do this work, and you guys understand that better than anybody else. So this is Orkney, which is the one just closer to the mainland. And I went it was just when the vaccines had come. So it was 2 winters ago. It was about this time 2 years ago, 2020. And this guy was retired, Orcadian, been there his whole life, and he was on the door for basically 2 years of the vaccination centre. Stood at the door, rain or shine, and it rarely shines in Orkney. And he was just relentless. He volunteered, he looked after everybody. And I went in and I said, I haven't had my flu vaccine. Is there any flu vaccine on the premises? Because I'd quite like it. And nurse said immediately, yes, of course, come here. So she does the consent, and I think she's given me my vaccine. And, but behind her are a series of, and that's how we do vaccination now, to make it quicker. We've got consenter in the front and then punters in the back who can give you the vaccine. And this, well, let's call her, what will we call her? Curvaceous, this woman? She was big, okay? She was big. And she was a bus driver. And she was loving it. The National Clinical Director was going to get his vaccine from a bus driver. If she said she was a bus driver once, she said it 46 times. So there's pictures of me in the papers with a bus driver with a needle, like. It was a fantastic illustration of, so the transport system in Orkney had given over its bus drivers to be trained as vaccinators in order for us to get through the whole Orcadian population. We did the Orcadian population pretty much quicker than we did anybody else. They all came very obediently in 2 or 3 days. 19,000 people or something in a week, done with Frank at the door and the bus driver in the back giving out the vaccines. It was a terrific example of that boundarylessness. You also can't do COVID without every piece of the puzzle. The other lesson here is that emergency or key worker status is not just us. I've learned that the people working at ASDA's customer service are pretty much key workers. Those working on our electricity supply, those in our police and fire services, everywhere else. You can't do it without them, and you've got to respect and honour what they are. So that's my first 2 lessons. So understand and lead personally. Don't look for others to do it for you. They're not going to do it, or they might do it, but it's a coincidence. It's not your problem. You've got to do it. And then my final one, and we'll try and do this a little bit sharp so we can have some questions, is have a method. Now, this is a lecture all of its own. So this is the core of quality improvement and person-centred care and analysis and statistical process control and everything else that people will know has happened in Scotland over the last little while. Deming is the father of this scientific method that drove systems change across US, Japanese companies, and eventually ended up in the public sector in health and social care through that IHI organisation I just mentioned. The example often used is Kodak, because Kodak was the finest organisation in the world for one piece of the puzzle, but never changed and didn't become a digital organisation and failed. But it is not necessary to change because survival is not mandatory. Deming was a grumpy bugger from the 1950s. There's black and white YouTube videos of him, and he's very, very grumpy. But his method is brilliant. And that's what we've done in the safety programme in Scotland, in a whole lot of other stuff. And just last week, I was here for the Children and Young People's Improvement Collaborative, which is a massive piece of work across all of Scotland's schools, doing literacy and numeracy and health and well-being across Scotland's schools using these types of methods. You need three things to make change happen. You need people with the will to do it. That's usually findable. It's usually not the whole room, but you can usually find them. You need the change ideas. You need the recipe for the change. Again, usually findable. Somebody's usually got an innovation that's available or something, or you can do some research, you can innovate. But you need execution. You need an implementation thing, and that's where everything fails. Pretty much everything fails. And you'll have examples of trying to do that yourself. Scale up and spread across a whole system like yours is pretty much impossible. NICE, you know NICE guidelines? So NICE guidelines are England and Wales, but we often take them so we don't have to redo them. Sometimes we take them and put a tartan wrapper on them and pretend they were ours, but actually they were NICE. So NICE sent a cardiac, so I still get them because I'm pretending to be a clinician. So they sent a 300-page cardiac guideline relatively recently. It's a massive thing about what you're meant to do with people with cardiac disease. All the evidence, all the drugs, all the thing. I mean, it was preposterous. And if the covering letter said, this isn't exactly what it said, but it said, look what the clever people have done. Good luck with implementation. That bit it did say. It said, best of luck with implementation. So their execution theory was luck. Brilliant. Absolutely brilliant. So that's this. So that is old system. So have you ever been on a short life working group? They're neither short life nor do any work. Are you familiar with these? I've been on thousands of these buggers. So you sit in a room, usually with people who actually know the system, because they've thought, well, we better get nurses. We better bring some nurses, because they understand. Okay. So we've got nurses and might even have a patient if we're really radical. But we sit in a room and we design the thing. Could be a new drug chart, could be a new admissions form, could be whatever you like. And then we usually meet every 6 weeks, and then 8 months later we've produced our thing. You know you're in trouble because it's usually laminated. My wife's a teacher. If you stand still in my house, you get laminated. And then you send it out to the world and you implement it. How does that go for you? It's garbage. So NHS Tayside, 9 Wells Hospital, 2005, they're trying to implement early warning scoring in the hospital. Quick story. Early warning scoring charts. Like, what's your heart rate? What's your respiratory rate? What's your blood pressure? You get a score out of 5. If you're 0, you're dead. If you're a 5, you should be at home. Yep. And everything in the middle gets people to come and help you. So this is what they do. 9 months. They spend 9 months designing the early warning scoring chart for 9 Wells Hospital. They print, I kid you not, they print 200,000 copies. And on the Monday, Jerry, who's the chief exec, who's my pal, puts them into ward-level bundles, sends them out on a Monday morning, says, look what the clever people have done. Please implement. Guess how many are used? None. Even the people on the feckin' group didn't use them. Jerry kept them in a cupboard for years. He would show visitors. He'd say, this is how not to implement change. This is 200,000 copies of the form that nobody ever used. Jerry then went to IHI. That's where I met him. And he did a thing called the Safer Patients Initiative. And unfortunately, this is much harder. But now you go to the work. It's not anarchy. You still decide you want the early warning scoring chart. So there's a leadership choice. So it's not you get to do what you please. You get the early warning scoring chart, and you say, right, what's the plan? Well, we're going to go to maternity. And in maternity, they say, you say, why didn't you use the form we gave you? We gave you the form, what's the matter with you? And they said, well, there was only space for one heart rate. We've got, in case you hadn't worked it out, we've got 2 heart rates in our patients. Oh, we never really thought of that. And then they went to renal and said to renal, why didn't you use our lovely, shiny, laminated Delawanne scoring chart? And they said, well, you're red, amber, green, we're renal. Everybody would have been dead on your thing. And they're all alive, so it doesn't work for us. We'd have been calling junior house officers every 3 minutes because your red is in the wrong place. Oh, really? Well, maybe we need a different one for renal than we need for maternity. No shit. Really? That's amazing. How long has it taken you to work that out? Well, 30 seconds, actually, but 2.5 years in reality. Why didn't you just ask us? We'd have told you. Long story short, within 6 months, Ninewells Hospital has a functional early warning scoring chart in every ward, in every patient, in every unit in the hospital, saving lives every single day because they use the method that's much harder. You go to the work, you test it in the work, you measure it, you change it, you measure it, you change it. It's still hard, and it's still designed, so somebody has still decided that's the thing you're going to do, but that's what you get. So you choose your goal, you choose your method, and you do it with predictive iterative testing. And in 10 years of the Scottish Patient Safety Programme that was based on some of that work at Ninewells, you get a 13% reduction in mortality. There isn't any other country in the world with a 13% reduction in all-cause mortality from 2014 to 2018. This is surgical mortality. This is the British Journal of Surgery in 2019. So this is pre-safety programme. We then implement the checklist, which is this the right patient? Is it the right operation? Have they had their antibiotics? Is the X-ray up the right way around? I mean, it wasn't radical, and it plummets surgical mortality by 1/3. That's people alive who would be dead. 36% reduction in surgical mortality. There isn't another country in the world that can show the surgical checklist at scale in every hospital. It took us 3 years to implement the surgical checklist. The Canadians did it in a weekend and got no change in mortality. Funny that. So they sent their checklist to every surgeon in Canada and said, please implement when you start operating on Monday morning and let us know how you go on. And there was no change in mortality. Then they wrote an article in The Lancet that said the surgical checklist doesn't work. That's not true. Canadian implementation doesn't work. The checklist works if you implement it properly. So this is Gawande and I publishing the first countrywide article in surgical mortality reduction following the checklist. But the point is the implementation plan. The point is taking the thing and doing it at scale. And don't try and do the whole country at once. There was 2 surgeons in Shetland who wouldn't do it. I tried to give them to the Norwegians, but they wouldn't take them. It was a German and an Iraqi, and they hated each other and hated everybody else. It was tough. But they wouldn't do the checklist because they didn't make mistakes. And so we just ignored them for a while. And then eventually, they still wouldn't do it, still wouldn't do it, still wouldn't do it. Nurses refused to work, still wouldn't do it, still wouldn't do it. And then eventually, you have to regulate. So of all your surgeons, you get to the end, and you might have to regulate for 2. And that's what we did. But you don't start there. You start with hearts and minds and will and getting your peer group and having pizza and counting the numbers and seeing how everybody's done and talking about the stories of the endoscope that was dirty and we stopped using it because of the checklist. And you spread those stories around. So those are my 3 lessons. But I wanted to come back to why we were thinking about the things we're thinking about. So my 3 lessons are understand your problem, and it's usually more difficult than you imagine. Lead personally, so step up, lead yourself, and then have some kind of method. It might not be the same method, but choose something. If you're going to make change, there are scientific studies and scientific evidence of how to do that change. You can learn it, just like you can learn palliative and end-of-life care, just like you can learn cardiology, but you have to learn it. You're not naturally good at changing. That's not how it works. So this is Wast View Care Home in Shetland. So I have slagged off Shetland a wee bit, but it's actually a glorious place to visit. This is 40 miles from Lerwick. It's in the middle of nowhere. It's in a small village, and it's the only care home for 40 miles. There's one shop, one pub, and a care home. And it was where our first 7 people died. You remember the story of the skiers in northern Italy? They came back to Shetland, and one of them came to this part of Shetland, and the virus ended up in this care home. And the first 7 residents died of what we now call COVID-19. But when they died, it didn't even have a name. This was really, really early. Nobody knew what it was. I went to visit. I met the families. I met the staff. I met everybody who'd been involved. It was an astonishing, resilient community. But there was a young lady over here who wouldn't speak to me. She was dead quiet, and she wasn't engaging. So I forced her to speak, and she was a Polish domestic. And she had lived in Shetland for years, but she was broken, completely broken by the whole experience. And she started to cry and tell me her experience. And the bus refused to take her to work because the community was scared of the disease. The shop wouldn't serve any social care workers. If you worked at the care home, you couldn't buy your bread and milk because the shop said, no, we don't. Imagine that in a small, isolated community. It's just unthinkable, and repeated millions of times around the world. But since those initial 3 months of that first wave, once they understood the disease, once we could help them understand the disease, once we understood it, they didn't lose a single other resident. Not one. It was a joyous, optimistic, happy place when I went to visit, with, of course, the history and the misery and the storytelling of what had come before. But even the families who I met were optimistic and grateful for everything they'd done. My final piece of advice before questions is, though, if you don't know your 1980s science fiction movies, you should watch Back to the Future. It's one of the finest movies ever made. But if Doc ever puts you in the DeLorean and he asks you to choose where to go, then don't choose 2020 because it was shit. Thank you for listening.
So, Jason, I imagine you're not the kind of guy who wants to come sit here, are you? You want to keep walking about, yeah? I assume you do. Do you want to keep walking around?
Great.
Yeah, I thought you probably would. So, I've got many questions here. I think people have been so entranced by what you had to say that they've not asked any questions. Personally, I've got PTSD, because you reminded me about wacky warehouses and my children emerging, covered in other people's body fluids and smelling of socks. It's just... I didn't want to go there, but I did. One of the things that I remember from COVID, when I was working in Birmingham, was the whole system came together in an extraordinary way it had never done before. We in the NHS, we wrapped our arms around the nursing homes, the care homes, nursing homes that were falling over. Community staff went in and ran them to keep them going, and so on. And then when the pandemic kind of went away, so did the partnership. I wonder, was that your experience here, or you managed to hang on to it?
I'm not sure it's quite as binary as that, but in summary, yes, that's happened. It feels, I've spent more time in care homes in the last 6 months than I've ever spent in my life. I've been in more hospices in the last 8 or 9 months than I've been in my life, because I've tried to go round and understand the system response a little bit more fully. And the difficulty now, of course, is we're not on one mission. The mission is too broad. We were all in one place. So the Chief Constable, the First Minister, the health, we were all facing in the same direction, and the whole of the population were facing in the same direction. That's not true anymore. We're now doing this great human endeavour of health and social care, but the criminal justice system is trying to catch up because the court system's behind and the education system is behind. And so it feels really hard. I hope that, so we're about to embark on the National Care Service in Scotland, which is the next step of our integrated care system. That will codify and formalise some of the relationships, and it will force some of those institutions to be pals. I think, though, underneath that, the relationships are better. I don't know if everybody would agree. Rami might be in the room from Chaz. I think the fundamental relationships locally, COVID has helped them in the main. But you then need the formal structures to come alongside and catch up with them. The two challenges that Tony mentioned in his opening, though, we haven't, I mean, there's not enough money and not enough people. So if I'm running a hospice in Rutherglen and I haven't got enough people and I haven't got enough money, you can be as kind as you like to me, but I've got a fundamental structural problem that I can't resolve. And that's the big challenge politically and organisationally for us for the next, certainly 2 or 3 years.
Okay. You mentioned what's happened in waiting lists and waiting times. Do we bring relentless focus that you talked about to try and bring those down, or do we actually have to think about doing things in a different way?
Yeah, both.
You know, in theory, there's about 15% of England is waiting for something, which I
so we've got
astonishing.
we think 1 in 6 are waiting in Scotland for something or other. So some of that is absolutely essential and should be optimised. And so some of you may have heard of the Aravind eye care system. It's a system I've been to visit in India. They do more cataracts in a single theatre than we can do in a whole hospital. It's an astonishing place. They've got no infections. They make all their own kit. It's amazing. And we're building a similar Aravind-style ophthalmic theatre just in Clydebank at the Golden Jubilee, not far from here. So bits of that you can optimise, because it doesn't matter how you maybe don't want to do the hips need done, the cataracts need done. So that's just a factory. It's not very nice to talk about it like that, but it is. It's a factory. So we can do that. There's then this big chunk in the middle, which is, let's call it non-communicable diseases. It's the diabetics, it's the respiratory disease, that has all got worse. So length of stay is up 1.5 days across the whole of the Scottish National Health Service. That doesn't sound like much, but if you multiply 1.5 days by 15,000 beds, that's quite a lot of increase. And that's because this group is sicker than it was, and we've still got the same tech to make them better. They often don't need surgery. There's often just a medical challenge. But then this bit over here is the worst of all. This is the frail elderly who weren't allowed out their houses for 2 years, who lost support, whose cafes closed, whose day centres we shut. That bit, that's the bit that keeps me awake at night. Yeah. And that's why we've got ambulances queued outside our hospitals. And that's not a waiting times problem. That's a deconditioning problem. So the raw waiting time stuff, frankly, needs money and resource and people and stuff thrown at it. I can draw you an equation for the First Minister to say, if you give me 350 million, this is how many of them I can do. I mean, it's not exact, but it's approximate. But if you give me 350 million for this, I don't know, nobody knows what to do. This is the really hard bit. And that means optimising the whole system. It means hospice care. It means social care. We've got 18,000 people in Scotland waiting for a care package at home. Not waiting for, we've got 1,800 in hospital waiting for a care package, but we've got 18,000 in their own homes waiting for a care package. They're only going to head into here. They are coming. Unless you get that social care package fixed. And that means resourcing social care, it means paying for social care, it means reforming social care. That's the bit that no government in the world has. Maybe the Japanese, maybe the Singaporeans. Pretty much nobody has resolved that deconditioned elderly. I hate that. That's a horrible phrase. It's impersonal, but you understand what I mean.
You've kind of taken us back to the way you started your talk, haven't you, in a sense, because while we're pretty good at pulling people out of the river of ill health, you need to go back and see what's pushing them in. So that integrated piece around education, around housing, et cetera, is really important to this, isn't it?
So I'm going to take you. So did you hear that? So that's the public health model of healthcare, right? I'm going to take it another level because I think it's wrong. And it's not me that thinks it's wrong. It's Sir Harry Burns who taught me that it was wrong, right? And here's the metaphor that I think works better. So the old-fashioned public health theory is the rubbish acute system. All it does is pull people out the river and fix them, right? And you just keep pulling the same guy out the river, but actually the fence is broken up here and they're falling in the river, so fix the fence, right? Great. It's a nice metaphor. It's not terrible. Sir Harry, who's my mentor, former CMO of the country and big public health thinker, he says, there's no fence and there's no people on the side. Forget it. Everybody's in the river all the feckin' time. We're all fucked. And there's barrels of oil, and there's stuff on fire, and there's cars, and there's all kinds of other stuff. What you've got to do is get in the river and help the folk that are in it, and you've got to give them the resilience. So you've got to help. Now, sometimes that might be a hip, but it might be addiction, it might be end-of-life care, it might be, but we're all in the river all the time. So we've got to give people the self-awareness, the self-care. 99% of care happens in folks' houses. Hospitals are repair shops. I mean, they're not actually the care. My mum's COPD is treated by her and my dad, with occasional visits to the guru in their lives of the general practitioner who they love. But he sees my mum four times a year and phones her every month. 99% more of the care is actually provided by my dad saying, "You sound like you've got a cough, should you up your inhalers?" They're in the river all the time. So we've got to provide them with the care and the support and everything they need, whether it's social care, whether it's hospice and end-of-life care, or whether it's acute care in the river.
Thank you. I'm bouncing around a bit because I've got quite a lot of questions flooding in now. I'm going to pick 2 or 3 out and just try and take them through to lunch, because I'm conscious, as Jason said, we don't stand between you and lunch. 600 hungry people, it's not good, is it? Great
when you have the
question
SEC lunch, you'll realise you should have stayed.
Actually, Toby's traumatised by the goulash in Liverpool, but that's another story. What's your top tip for successful implementation of integration for your English pals? That's the actual wording I've got here.
So it depends what they mean by integration. If you mean integration of systems, the secret is to get the 2 ends right at the same time. So you've got to give space for those in the front line. So let's take a social care, acute care example. So if it's a discharge problem, the hospital think it's social care's problem, social care think it's the hospital's problem because they can't get them out in time, or they can't manage them, or they don't get the drug list, or they don't get the imaging, so everybody just de-optimizes. So you've got to get the actual workers to talk. It's rose-tinted glasses, but in the good old days when I was a boy, in the small hospital I worked in the south of Glasgow, I knew the GPs' names, I knew the pharmacists' names, I could talk to them, I knew where we were, I knew the care home leaders. So I did oral cancer, and I could say, look, I'll come tomorrow myself, I will come visit, but if you take him today, I promise I'll come and see him tomorrow. You won't be taking any more risk than you're taking today, etc. So that's relational, but then at some level, the leaders have got to protect you and make that happen for you. So there's got to be rooms with people in suits, men and women coming together to actually work out the structures of that. And that's all this crap about information governance, and we can't share this and we can't share. Get over yourself, honestly. My mum and dad couldn't care less. They think you already share, and yet but the medical record doesn't move to the care home. What? They presume the medical record moves to the care home, and we put all these artificial blocks in place. So we've got to fix all of that top bit. So I think it's optimizing freedom in the front line, and then at the top end, you've got to force. And that's what we're trying to do with the National Care Service. That's why we think we need a bill. I rarely choose a parliamentary bill as implementation. But I think there is something in the care service that requires structural change that needs a parliamentary bill through the Scottish Parliament.
Okay, thank you. So, actually, the first question I got was about a bill, and it's one I have to put to you in this setting with these folks in this room. There is a live conversation in Scotland in Parliament about assisted dying. If that goes through, if that's accepted by Parliament, what will that do, do you think, in terms of the relationship between the Scottish NHS, the hospice movement? Where would we find a way through?
Yeah, it's a long way from going through Parliament. Remember, 2 different things. So the National Care Service Bill is a government bill going through, a bit like the Health and Care Bill for the UK Parliament for NHS England. We have the National Care Service Bill going through with a number of other things. But just as in Westminster, you can do what's called private members' bills. And there's a private members' bill going through the Scottish Parliament on assisted dying. And there's been a number of attempts over the years to do it. Margot MacDonald, who was terminally ill herself, is the most famous version, a wonderfully inspiring woman who died in service and was trying to put it through. It failed a couple of times. But now Liam, can't remember. So it's coming back through. It's not, private members' bills are not ready for the statute books. They never are. Because they don't have the lawyers and they don't have the civil service and they don't have the thing around them. But it is gathering momentum. It's certainly, forcing the conversation at a political level and at a community level, and I think that's a worthy thing to do. I don't know where that will end up. At a minimum, I hope it ends up with a very mature conversation about a good death and palliative and end-of-life care being prioritised and really important. Because I work for the government, I'm not going to give you my personal view of what happens at the end. I think at the assisted dying end of it, I think it will be a free vote in Parliament and it will be conscience. We're probably closer to it than we've been in the past with the present setup of the 129 members of the Scottish Parliament. But I hope whatever happens, the dialogue is mature, is person-centred and family-centred and talks about it. I think we're a long way from being the first country in the UK to actually have an assisted dying bill.
Okay, thank you. One last thing then, because we've got 2 minutes left. I noticed you mentioned as well your connection with IHI, and you did some work with Don, didn't you, Don Berwick? I remember Don came to Birmingham once, and we gathered the great and the good and the not so great and good around a table. And somebody asked him a question about how we should get together and work better together, expecting the kind of, structural response. And Don looked at this guy, chief exec of a very large trust, and said, just do what you do with love. How does that resonate with you?
So Berwick is my hero. We were speaking at a thing in a couple of weeks' time. So we were on a prep call last night, he and I, and we haven't seen each other for a few weeks, so he's on, and this young boy comes on. This is Don Berwick, right? For those of you who don't know him, people touch him as he walks past. I mean, he's like the guru of healthcare systems improvement. He's a hero. But he's in his early 70s and semi-retired, and so this young boy comes on and he's teaching us how to use MS Teams. And he says to Professor Donald Berwick, the inventor of Obamacare, says, have you done a webinar before? And if he'd said that to me, I'd have said, you're a feckin' idiot. Of course I've done. And Berwick says, yes, done a few, thanks. But you could maybe talk me through it. The most gracious, lovely man, just the most beautiful response in the world. So yes, he lives it, and he's right. He's also been the head of CMS in the American government. I mean, he's got a spine. He's not scared to stand up to your big boy chief exec if that's what it needs. But the core of what he does is grace and love and kindness. And if you can start there, you still need the Excel spreadsheet that says there's no money and I need 4 more band 5s. Yeah. Could you flipping get your... That still needs to happen. But if you're doing that from a place of kindness and love and a core desire to make it better for those we serve, I think that's good advice.
Fantastic, Jason. Thank you so much for stimulating. Thank you. I think what I'm supposed to say next is lunch is served, but for God's sake, don't all run at the door at the same time, will you? I've got a question from somebody called Howard, and if Howard would like to pop and have a word with Toby, that would be really helpful as well. Thank you. Thank you all very much this morning. Thank you especially to Jason. Thank you to Toby. Thank you to everyone. Great morning. Thank you. Great start.
What's Howard say?
to chew on, but that would be no fun. That would be no Every damn song I hear is a blunt reminder that I'll never lead a crowd to tears again. And now I realize that the booby price was becoming kinder. I would let them burn me down on an open stage. At 17, you're free to show your bag. God help the child when she returns. When she But it's my pill to swallow, and you can say my bleeding heart won't beg or borrow. If it feels good to make me wrong, but don't you need some troubles of your own to chew on? But that would be no fun. But that would be no fun. That would be no fun.
Hi there, can you hear me?
Guarded, I've been broken hearted. I don't know when it started, but you're showing me where it ends. Excited, yeah, we got perfect timing, but also kind of frightening. I've already let you in, and I'll follow wherever you go. I'm just hoping that you don't leave me alone. Don't leave me
from the day I read that, that's sort of been like my life's moral. You know, whatever happens, happens.
Are the other two guys waiting in the wings?
Yeah, no, I think they're shutting up.
So good afternoon, everybody. Welcome to our first session of the afternoon, looking at recruitment and retention, that big nugget out there. For those of you who don't know me from all the Zooms over the last few years, my name is Rowena Lovell. I'm Director of Strategy and Governance at Hospice UK. I feel I should walk around with like a television screen frame around me so everybody knows. So I'm delighted to welcome you to this session. I just have a few things to say to let you know that this session is being recorded. So the recording will be live in about 10 days' time on the online platform. Because we've got online viewers, delegates today, all questions to be put through Slido, and I think there are details at the front here of how to access Slido and put your questions through. What I'm thinking of doing, because we've got three very intense presentations to get through, is to go through all presentations first and then to go to questions and answers so that we've got a chance for people to process the last presentation before the next one. I just wanted to let you know that we've got two speakers this time joining us virtually. Paul Knott, who's a recruit and retention consultant, and Professor Vanessa Taylor, Professor of Cancer and Palliative Care at the University of Huddersfield. For various reasons, they're not able to join us in person. So they will be joining us remotely. And then my colleague, Dr. Paula Powell, will be presenting the third presentation at the end. So just sort of like, I mean, we're all aware, recruitment and retention, as Toby said this morning, workforce is one of the biggest issues facing our sector at the moment. Paul is going to look at ways that we're recruiting, what attracts the most and the best candidates, and then how can we keep them, which is often the biggest challenge when we get talent in our organisation. How do we keep and grow that talent? Vanessa will bring us up to date on NHS England work in developing a career pathway and the education framework for palliative and end-of-life care. And Paula will then discuss the work she's been part of in Cheshire and Merseyside to look in depth at the workforce. And particularly, she's just been discussing with me the development of specialty doctors in palliative care. So I'm going to hand over to Paul, hopefully, or fingers crossed that technology works, otherwise I'm just going to die on stage. So hopefully Paul will be able to join us. Paul started his career in fundraising, working across a range of income streams, and became a charity recruiter and a career coach, and he's actually working with us at Hospice UK as well in terms of our own recruitment and retention. So Paul, over to you.
Thanks so much, Rowena. Hi, everyone, both in person and online. And unlike Rowena, I do have a screen around my face. So yes, as Rowena said, I've been a recruiter for a long time within the sector. I now help organisations to recruit and retain staff because mostly the solutions to it are fairly easy and do make it enjoyable, both for the organisations and for the applicants. I'm going to talk very quickly today because I've got a short amount of time, and I do want to cover both how the recruitment market looks right now. Spoiler, it is horrendous, but I also want to share with you some easy solutions that you can take away with you today that will actually really improve that for you. I will mute myself every now and again if I need to cough, because I had COVID a couple of weeks ago and the cough is hanging around. But to move on, really, there are plenty of themes that I could cover in terms of recruitment and retention if I had days to talk to you, but I don't. So for today, I'm just whittling it down to 4. Really, it's the job specs, advertising your roles, making the offer, including the magic of Wednesdays, which I will come on to at the end, and about how to retain your best staff. Sure.
A bit of a technical hitch. I think it seems to be double playing you. You've got an echo at the moment, so they're just sorting
single
it out.
playing
I
me
think,
is
and I
bad
don't want you
enough.
to get too far in before we miss the best bits.
That's
And
fine.
so I think they're just sorting it. I'm hoping somebody will wave me when it's all right to start. Are we doing?
Do I need to talk every now and again to test?
Are you able to try talking just to see how we...
Do you have one of me or 2 of me?
Can we hear you?
Can you hear me?
Yep, that seems better.
Great stuff. I mean, 2 of me is a nightmare scenario. Is that sounding okay? Is that okay, Rowena?
No, it's not working. They're doing something with something behind me. Oh God, I hate technical stuff. Anybody know any jokes or can sing a song or in a minute? Can you sing, Paul? We're just waiting for a minute. They're doing something with the audio. How are we doing? If not, I might... No, they've still got something up on the screen. Yeah. No, Mum, wait, it works auto, doesn't it? So it's only when I speak. Oh, I don't know. They turn me off normally. Stu, how are we doing? Okay, so I was going to say, Paula, how would you feel? Yes. If they could go to Dr. Paula Powell's presentation. Yeah. 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 So, Paul, I think they're going to cut you off while they sort out some technical issues. I think something's gone wrong with some sort of streaming. So they're going to sort of come back to you in a bit, if that's okay. And I'm going to move to Paula, who's going to present in person here while they sort out those issues. So
Sounds
thank
good.
you. We'll come back to you. Sorry, Paul.
That's all right, no worries.
So on that basis, they'll be moving to Dr. Paula Powell's presentation. I think she was hoping for at least 40 minutes, a breathing space in between. So Dr. Paula Powell is Consultant Executive Medical Director at Willowbrook Hospice on Merseyside. She's also Clinical Lead for Cheshire and Merseyside Palliative and End of Life Care Network and the Clinical Lead for Palliative Care in North West Strategic Clinical Network. And she's the Workforce Lead for Cheshire and Merseyside and has a particular interest in career development of specialty doctors working in palliative care. So, Paula, thank you very much for stepping in. Dr. Paula Powell's presentation.
Thank you. I'm a bit vertically challenged, so this down. Thank you for inviting me and sharing the work that we have been doing over the last 10 years now in the Cheshire and Merseyside network in particular, but North West Coast network is included in that. My name is up there, but I must say that two of my very close associate specialist colleagues in Cheshire and Merseyside, Ezra Suleimani and Helen Bonwick, have done a huge amount of work to support what I'm going to describe to you today, and their work is ongoing. So I just wanted to make sure that people knew that this wasn't just me that was doing this. So why am I so concerned about the development of SAS doctors? Well, if you look at my title there, you might think that I've come from the rarefied atmosphere of specialist training, but I didn't. I was a GP for 8 years, and I was a staff grade doctor, as they were previously known, for 13 years, and I did both for a period of time. And then I gained a CSER through, so a Certificate of Equivalent Specialist Registration, through a lot of hard work, and I have to say, it's harder now for people who are wanting to do that, and I was successful in doing that in 2009, so I've been a consultant since 2009. So what do I think the issues are with regards to the issues for specialist, specialty and associate specialist doctors? Well, we all know that there are many workforce pressures that exist across all specialties, and recruitment and retention, as we're talking about today, is a huge challenge, and it's a huge challenge in particular for hospices. In Cheshire and Merseyside in 2022, we conducted a workforce review, and that is one of the resources that you can have a look at later if you want to. We'll share that with you. But that basically showed that we had a 20 whole-time equivalent gap in the consultant-only workforce. That didn't include gaps in the SAS doctor workforce at all, of which there was a significant one of around 6 whole-time equivalents. We also found that very rarely were there any SAS doctors in the hospital setting. So we don't have the workforce for what we need to do now, and we certainly don't have the workforce for what we're going to need to do in the future. Some of you will be aware of what's happening with regards to the training of future consultants in palliative medicine. And shape of training it has the potential to make a really huge difference. We've seen applications for training fall off a cliff this year, and given that we've got a 20 whole-time equivalent gap now, and in Cheshire and Merseyside we've only got one doctor in training likely to come out in 2024, you can see the issues we've got. The particular issues for SAS doctors, many of you will be aware, because you might be one yourself, is that they have fewer opportunities for career development compared to doctors in specialist training, and often they can be unsure where they get any guidance even to do that comes from. The other thing that particularly has concerned me over a number of years is that specialty grade doctors can often be asked within hospices in particular, I think, to step up into clinical leadership roles without the support or training to do that. And as I've just alluded to before, we know that the population need for palliative care services is going to increase hugely by approximately 40% in the next years. So we've got a real problem on our hands. So if you look at the SAS doctor establishment in hospices in particular, what we know is that they've got a huge amount of experience. Often they're not just doctors in hospices, they bring experience from general practice and elsewhere, which is hugely valuable. We do know that their interest in career progression is often really high. We do know that most specialty grade doctors work in hospices, some in community settings as well, but very few actually in the hospital setting. We do know that job plans, where they exist, and I say that advisedly because actually SAS doctors tell us that sometimes they don't have any kind of written job plan or even contract, they're often service provision focused. So you are appointed to do the do. You're appointed to see the patients. You're not appointed to do quality improvement work, audit, education and training, although a lot of them do. And one of the nubs of the problem is, I'm sure you will always all be aware of, is that pay and terms and conditions in hospices in particular is very rarely fully aligned to the NHS. And I include my hospice in that. The GMC workforce report from just this year talked about SAS doctors in general and said that they were a significant percentage of the workforce and likely to be the majority by the end of this decade. More SAS doctors leave the profession than any other grade of doctor, but that they repeatedly report barriers that hinder their development, some of which I've just mentioned. And they have said that it's imperative to address career progression, education and training for specialty doctors. So what is the position of the Cheshire and Merseyside network? Well, what we acknowledge is that SAS doctors often have skills and knowledge, sometimes at or above colleagues who are consultants or specialist training roles, but this often not valued or recognised. SAS doctors can have particular challenges when accessing opportunities for professional development due to funding and service pressures in the voluntary sector. So we may well all wish to develop our SAS doctors, but funding issues, being charitable organisations, is always there. However, supporting the education and training of SAS doctors and benefits for patients and the wider system means that we're going to be providing better, safe and effective and sustainable services. So since 2012, Cheshire and Merseyside Palliative and End-of-Life Care Network has worked to support SAS doctors in our region to access training and development guidance and opportunities, and I'll go through some of that. So there are some key enablers that we've put in place, some of which are available for use nationally and regionally. Early on in 2014, Helen and Ezra developed a framework for SAS doctors, which was a 4-year framework of training, which described what good would look like. Now, that was mainly to look at somebody who might want to submit a CSER application and mimicked the 4-year training that a consultant, a potential consultant would be doing. But it's quite a practical guide. That has been available since 2014 and it's now in its 3rd iteration, so it's updated in 2020. And again, that's available for use and it's one of the resources that we can share with you. We also made sure that there was a SAS doctor representative, which is currently Helen, on our educational supervisors group, Northwest Educational Supervisors Group, to ensure that their issues and their development needs were discussed with and alongside those of doctors in specialist training. And that has had a huge impact, and I'll explain a little bit in a minute. We also made sure that SAS doctors had the opportunity to be part of the education and training program that specialist trainees had. Interestingly, there was a little bit of reservation in terms of including doctors who weren't in specialist training, but now they've engaged really well. The problem is, it's often them who have to stay back at the ranch while the specialist goes and gets the training, but we're working on it. And actually the pandemic has made a huge difference, because now it's virtual and they can tap into that, and they can tap into recordings, which has really, really helped. And we've also created a network, a SAS doctor group, which we support with a little bit of money and some admin and project management. So some other things that we do. So the SAS doctors now have quarterly meetings and development away days to help them think about their own needs, to talk collectively about what would help. They conducted a survey themselves, and out of that they told us that they would like to be able to rotate between different organisations and get experience elsewhere, in another hospice, in a hospital, in a community setting. So we set up a working group to make that happen. And actually since then, a number of doctors have completed rotations elsewhere. So we do a matching exercise, and 2 of my doctors already have been over to our tertiary cancer centre to get experience there, and 1 of the doctors came over to us, and it was really beneficial for everybody. And so we're going to do more of those in the future. We've also developed a framework, and I think this is a really big piece of work that some of you might be really quite interested in, to assess responsible clinicians and medical directors in hospices who were not on the specialist register. Prior to this, there was nothing that would actually describe what the competencies were for somebody who wasn't on the specialist register but wanted to be a responsible clinician or a medical director. I can't go through this in detail. It's quite a detailed framework, but essentially we have a 3-step process. So the doctor benchmarks themselves in terms of their training experience against the framework that I mentioned earlier that Helen and Ezra had put together. The employing organisation is then asked to conduct an appraisal against that, and to make sure that they have a job plan that meets their needs, and we ask the employing organisation to sign up to that. Then that's submitted for an external assessment. This isn't an accreditation, but is actually a quality mark, if you like, and that's what we're trying to work towards. And this framework has now been recommended and included in the Palliative and End-of-Life Care Handbook for Integrated Care Boards. So what impact have we had? Well, SAS doctors across our network tell us that they feel recognised for the significant contribution that they make in the provision of specialist palliative care services. They've been empowered to seek opportunities for their own development into clinical leaders in their organisations, and we've currently got 4 doctors across the network who are actively looking to submit CSER applications to get onto the specialist register in the next 18 months, which, when you think that we only had 1 doctor coming out in 2024, is really, really important. And also our frameworks have been adopted regionally and nationally as good practice guidance. So what next? Well, we want to increase rotation opportunities. We want to get them out more and more. I've just learned this week that the bar for hospital experience is changing, it's increasing. How do we get that when very few doctors in SAS doctor roles actually work in hospital settings? We need to think innovatively about that. And we've just done a piece of work on the key principles that describe ideal medical establishment in hospices, both in and out of hours. So what can you do? Well, ask yourselves these questions. How do we fare against the SAS Doctor Charter? anybody here actually know that what the SAS Doctor Charter is? Because it's not my charter. It's a national charter for all SAS doctors, and it's a benchmarking exercise. I would suggest that you maybe go away and see if your organisation employs your SAS doctors against that, those. Think, what can we do to improve job experience and job opportunities? Ask your doctors what good looks like. I was at a conference last week, a leadership conference, where they were talking about the joy of job crafting and asking people what it is that they need and want from their job role. Because if we do that, we keep people happy and in their roles, and they don't want to move on. And then think, can you collaborate further with other hospices, other organisations to maximise the career development opportunities and make the most of the individuals that you've often got working within your organisations. So these are the references and resources that we'd be happy to share, and these are the email addresses for the three of us if anyone would like to ask any questions. And I've put any questions, but I'm going to come back and wait for the others. Thank you.
Thank you, Paula. That was brilliant, and thank you for stepping in just in the nick of time. I understand I can go to our virtual presenter. No, now we can't hear Paul at all. Is the sound on? Lord. This is just my worst nightmare. It was such a good start as well with the first plenary this morning. And then we ate. We had lunch, and lunch just kiboshed the lot. So just while Stu's running up there to sort the technical issues, Paul, please, my apologies, please bear with us while they try and sort it out. Paul, I'm just going to come to Paul. And what do you think some of the biggest challenges faced? I know you presented sort of like that, but what do you think some of the bigger challenges might be we face?
Well, I suppose I outlined in the presentation that we are in a situation, I think, particularly in palliative and end-of-life care, where we have a wholly inadequate workforce and limited opportunities to make a difference to that with the way that we're doing things now. I think we have possibly focused in the last 20 years on growing the specialist workforce, but we haven't actually been able to keep pace with the guidance on that. Hence, across Cheshire and Merseyside, we've got 20 fewer consultants than we actually need. I think alongside that, we haven't really looked at understanding and developing that key workforce that we've had sitting alongside consultants for such a long time, and look to see how we can use them most effectively. Because the vast majority of the doctors I know in SAS doctor roles are hugely experienced and want to do more. So I think we just need to start thinking outside of the box and probably being a bit more pragmatic than we have been.
Interesting. In what way do you think?
Well, I think we need to think about workforce more broadly. I've focused on SAS doctors, but we have extremely experienced nurse colleagues as well. So I think we need to be thinking about how we use the medical and nursing workforce together to respond to this
Sound check, sound check, sound check. I really hope you can't hear me in the auditorium because I've just been asked to do a sound check, so I'm just saying anything for 1 minute. If you can hear me in the auditorium, I can't hear you, so I really hope you can't. Rowena, if you can hear me, please stick your thumbs in the air. Checking for sound. I hope I'm not coming through in the auditorium, but I'm guessing not.
I need to speak as well.
Hello.
Hello.
I can hear you.
We're in a different world, aren't we?
Cross-learning.
Yeah.
Thank you. I am hoping that the pressure is off us on the stage.
Now, Rowena, I can't hear you, but can you put both arms in the air if you can hear me? Rowena, if you can hear me, can you stick your arms in the air? Because I can't. Yes, wonderful. So myself and Vanessa can't hear audio sometimes from the auditorium. All I can currently see is Vanessa, which doesn't help because she's in the same boat as me, you, Rowena, and a bird's eye view of the auditorium. So either, if you can't hear me, Rowena, stick your hands in the air, or delegates, if you can change seats and form yourselves into the word stop as seen from above, that'd be perfect. So Rowena, just to check before I go ahead, arm in the air if you can hear me. Hey, lovely. Right, so where are we in terms of recruitment? As I say, if you've tried recruiting yourselves recently, it is pretty bleak at the moment. I've never known it like this. Applicant numbers have dropped through the floor for most roles, but there are some obvious reasons for it. So a lot of it is our sector is less attractive than it used to be. We've had various scandals in sector organisations and central bodies which have put people off because they've hit national press. First jobbers and education leavers that I speak to, who traditionally would have been targeting the charity sector, I find are looking at other sectors like the tech industry now because they're getting that sense of shared purpose, that sort of cool factor that people would have traditionally targeted our sector for. And they get that sort of feeling they're giving something back through the corporate social responsibility that their corporates do. More people have left the sector. We've heard about the great resignation happening across the country during and post-COVID, but it's affected our sector more than others because like other sectors that make a difference, like teaching and healthcare, and with hospices, it's a double whammy of charity sector and healthcare, our sector has always had more people in it than other sectors who are not the main breadwinner in their household. So it gives more flexibility to leave. So if the job is getting too hard, and there are plenty of jobs, as I'm sure some of you know, that are doing two people's job in one, or it's too stressful, people have just found it easy to take early retirement or just walk away and take something closer to home that's easier. Then you've got uncertainty. As a recruiter, you would always see that applicant numbers would drop when you're coming up to a general election or something like that, because people wanted to see what was going to come out of the new government and funding and things like that, so they stayed put. Now, we've not had a general election. We've had Brexit and a pandemic. So there's all this uncertainty, which means people are tending to move less and the best people are being looked after by their employers, which is a good thing. But when you're recruiting, it's not a good thing because you're drawing from a more limited pool from before. And in terms of people who are job seeking right now, the things that are important are flexibility more than anything. And that doesn't just mean letting people work at home 1 day a week. It means being as flexible as you possibly can and trusting people to work more effectively at home. And that trust counts for so much. And for those worried about productivity, and I still hear this a lot, I've been banging the flexibility drum for more than 15 years, I think, because I truly believe you get more productivity because it forces your managers to manage people based on outputs rather than on presenteeism. And we've all seen those people looking busy at their desk, achieving nothing all day, right? Salaries have to be fair. Gone are the days when you could say, although I still hear it a lot, we're an amazing charity. People come to us even if the salary is lower. They just won't see your ad anymore because people aren't looking in print anymore. They're looking on websites. So they're putting in, as I'm sure you do when you job search, looking at a salary range. And if they're putting in 30 to 35 and your job's 28, however good your charity is, and you might be next door to where they live, they simply won't see your role. So your salaries have to be fair and equitable with others that are paying. But even a small amount can make a difference. So you see a lot of salary scales that are paying something like 29,995 as the top end. But if you just add £6 to that salary, you're tipping over 30,000. So you're going to see that whole other tranche of people who have put in a field of 30 to 35,000, say, in their job search. So think about even those small amounts of money. Also, applicants looking now are hyper aware of criteria being appropriate to the role they're looking at, and they're calling it out when it isn't. So if you're asking for a degree when it's not necessary, or a certain number of years experience, you need to get rid of all that, because not only is it stopping people applying, but you're going to get called out on social media and it's going to impact you as a brand. So I am conscious that not only do I speak quickly, but this has been really doom and gloom so far, but it really isn't all doom and gloom by any means. It is hard, but most organizations are rubbish at this. So if you're just a bit better, you can really stand out from the crowd, and you only need one person for each job. And as long as you get yourself in front of them, keep them engaged, that is really all you need. So how to get them engaged? Well, firstly, with marketing, it's your job pack. This is absolutely a marketing document. It's not just a list of responsibilities. You need to make it sell your role. So the first easy solution, and really the key thing within this, is not only providing information, but removing fear of the unknown. So get an org chart into your job spec. There are some people out there who say love being in a team of 4, all of which are doing the same thing and can bounce off each other. And there's others who like being the one person in the organization, having total autonomy and doing their thing. But if you're not clear on your job pack, which of yours that your role is, both of those people may choose not to apply because they just don't know whether it's for them or not. You can also, the line manager role, we all know is probably the most important relationship in a role, but often you just see the person's job title. Include a biography of that line manager, put a link to their LinkedIn. You could do a video and put it on YouTube of them talking about the role and put a link to that. Everyone's looking at these things on tablets, laptops, smartphones. You can make them interactive and really bring them to life. They're not printing them out anymore. Get something in about the team and maybe the work they've done recently. If there's a link to some of the work they've done, put that in as well. Show what the office looks like. Just all you're trying to do the whole time is bring the role to life and allowing them to picture themselves in that role. And think about the selling points of the role. If it's an existing role and it's doing really well and it's successful, put that into the job pack. If it's a brand new role, get in the reason about why it's been created in the first place and what things are in place to make sure it succeeds. So add in all those good bits, and you know what they are because you care about those things when you're job searching. Get in all the good bits, get rid of all that non-essential criteria. As I said, I'm still seeing roles with 15 or 20 essential criteria, and they're clearly not. Get rid of degrees, driving licenses, all of those things. But you really only need 5 or 6 criteria. That's truly the essential criteria. If you whittle it down to those, it makes your shortlisting and interview scoring way easier, and it will increase the number of applicants, so you've got more people to look at and choose who you think is the best fit. Finally, include your benefits, not shopping discounts and cycle to work schemes, because frankly, nobody cares about those enough to make a difference about whether they apply or not. What they want to know is parental leave, pension, and annual leave. Those are the only 3 important things, and you need to get those in so people don't feel they need to contact you to ask about them. So you've got your job pack, it tells a story, it'll encourage good people to apply, but now you need to get them to look at it. So you need to get an advert out there. So similarly, once you've done the job pack, it's really easy because you're just using that in a more concise form. You get your selling points of the role and you get those front and center. You get your actually essential criteria in there, because if there's only 5 or 6, you can get them in the ad and then people know whether they are actually right to apply for it or not. You can put a quote from a member of staff. It's really powerful, this. You can put it in the job pack as well. If the person who's leaving the role or an existing team member likes where they work, get a quote from them, put it in. It really endorses the role and makes people buy into it and believe it. And if, like so many organizations, you have slightly weird job titles which don't really say what the role is and aren't what other organizations call that job, just use a generic job title on the ad. It doesn't matter. And it's pointless you using your weird job title that everyone in your organization knows if nobody's going to understand what it is and see it. Once you've done your ad, yes, get it on a standard job site. They do work. Job seekers use them. But you want to get to all those passive people who aren't necessarily looking. So use social media and completely hammer it. So put it on the jobs page on your website, then ask your staff to share it on the social media they use, whether it be LinkedIn, Twitter, Facebook groups if they use Facebook for work-based stuff. But don't just get them to share the ad, get them to write a bit of narrative about what they feel about working there, because then that not only promotes that role and makes people within their network more likely to apply, it also just sells you as an employer of choice and starts building your brand as an employer. And finally, put your contact details on the ad. Not that many people call you, but it will be the good ones who call you. And knowing people can call, makes people trust the role more because they know it's being open and that you're willing to take questions, so they almost don't feel the need to ask them. And those that do, you get a chance to have back and forth. You get to understand a bit about them, and they get to ask those questions they need to know before they apply. And it will be the good ones that do that. So now I'm going to skip through some really fun parts like shortlisting, removing bias, how to interview well, all those kind of things, and actually jump to the riskiest part of the process, making the offer. And I will talk about Wednesdays. So you've interviewed, you decided who your favorite candidates are, and notice I'm saying candidates rather than candidate because it is plural. You ideally want a second choice and a third choice. If you can, don't fixate on just one person. Doing this well is amazing. It's incredibly high risk, and that's what you're taught as a recruiter all the time. This is the riskiest part of the process. Everything you've invested, the money, the stress, all the time, all of it hinges on doing this moment well. And if you do it well, it's lovely. I miss this part of being a recruiter so much because, you know, you phone people up, they squeal, they shout, they cry in a good way. It's lovely. But you've got to have a bit of thought about it first. And firstly, it's often HR that do it. Don't let HR do the nice bit. It should be the line manager doing it because you're the one who can answer questions if you need to. So train your line managers to have a bit of thought beforehand, because generally speaking, if the line manager calls up, they've got two thoughts in their head. They think, I want the person to accept, and maybe they're thinking about the start date, but you need to think about some other options. Because yes, if they phone up and the person says, that's great, lovely, jumps around, then that's easy. It's not done, but it's easy, you're halfway there. But they need to think about two other options that might happen when you phone and offer somebody the job. So if they phone up and they get voicemail, what can happen is the line manager leaves the job offer on someone's voicemail, which is the biggest world of nightmare you can have in recruitment, because if that person doesn't respond to that voicemail and call you back, you've just left a legally binding offer on someone's voicemail. How long do you leave it before you offer it to somebody else? Long enough that you're going to have lost all the other people you might want to offer to anyway. So don't leave offers on voicemails, but do ask them to call you back, and they will if they're interested in the job. The other option is that they say no thanks, which is totally fine. But if you haven't prepared for it, if a manager hasn't prepared for it, it's a pretty uncomfortable situation to be in. The person saying no feels uncomfortable. The line manager doesn't really know what to say. So generally, they both want to get off the phone really quickly. So they say, okay, that's fine, and put the phone down. And then you never getting that person back. But from my experience as a recruiter, very often, if you just know that it's okay to say to somebody, oh, that's fine, but can I just ask why? And ask them about it. Very often, they just need a bit more information. They may have made an assumption in the process which wasn't correct. They might have another offer on the table. And then if you've got a good relationship, you can have a chat about that other offer and what it's like and the pros and cons. And they might choose yours in the end. And often it is just something as simple as, I had lots of cases where somebody would say, oh, no, I'm saying no to the job because actually I can't start for 2 months and I know they want somebody starting in a month. So they've said no just because they think it's too long. But obviously, you know that if they say no and you have to go back out to market, 3 months if you're lucky before you get another member of staff. So just managers need to think about just engaging with people if they say no. And usually speaking, you can turn them around. And if they do say no and you've done it in a quick fashion, you can move on to your second choice and a third choice. So you've got to do it quickly to do that. Otherwise, the longer you leave it, the longer everybody thinks, I haven't been contacted, I obviously didn't get the role, maybe I didn't want it anyway. And then when you do offer it, they're far less likely to say yes. Also, once you've done this, you've got your person, all of that, please don't forget to give feedback to the other people who have interviewed, because it happens so often, and it's just unfair to people not to give them feedback when they've done an interview for you, but also it will get passed on to friends. Other people won't want to apply for you. And I've heard of more than one instance where somebody didn't get feedback, had a bad interview experience. Nobody knew that that person's uncle was a major donor of that charity, who subsequently didn't give their annual donation of tens of thousands of pounds after their nephew having a bad experience. So it can impact you financially as well. But it is just a fair thing to do anyway. Now, I did promise Wednesdays. I love Wednesdays for job offers. It makes all the difference. Most organizations do job offers on Fridays because they've interviewed in the week. They give a job offer on Friday. Friday is the worst day to do a job offer. Please try and avoid it. The reason Wednesdays are great is, if you imagine you've got a couple of options, you've got your first choice. If you phone up and offer them the job on Wednesday, most people will want to think about it overnight. That's fairly standard. So that person thinks about it overnight. Maybe they come back on Thursday and for whatever reason, they decide not to take the role. That's fine. You can't convince them, whatever. You then offer to your second choice, who's still interested because you've done it so quickly, remember, and then they think about it overnight. So on Friday morning, they phone in, accept, everyone's happy, but that means they can resign from their job they're in right now on a Friday. Now, if they're really good and you think they're great, their employer might think they're great as well. So that employer might want to keep them by offering them a pay rise, a promotion, whatever. But if that's happened on a Friday and they've resigned, it's very unlikely that employer is going to be able to turn around that offer or salary increase on a Friday. Therefore, your favored person has the whole weekend in the headspace of being in your role, thinking ahead, thinking about the new role they're going into. So by the time they come back to work on Monday, even if they do receive a better offer, they're far, far less likely to accept it. I've been doing it that way for a long time now. Since I've done offers on Wednesdays, counter offers just don't tend to happen. So like with so many of these things, as I say, it's a tiny little tweak that costs you nothing, but can make an enormous difference. So I've mainly talked about recruitment. Retention is way better because if you retain your staff, you don't need to recruit as often. So it's easier and cheaper and happier. But as a sector, we are so bad at retention. And really, the most important thing is just to listen to your staff and what they need. And a way to start with this, if you don't do it already, is exit interviews. Still, lots of organizations don't do them. If you don't, you really need to start. But often in an exit interview, people get asked, why are you leaving? And they tend to say something like, oh, it's a career move. Don't ask them why they're leaving. The key thing to ask to get the information is to say, why did you decide to leave now rather than 6 months ago or in 6 months' time? That's the question that will get you the much more decent information from them. And then once you start to build up that information from exit interviews about why people decided to leave your organization, you can work out how to solve those things to make people want to stay. So that's the first bit of listening. The other thing is to train your managers to think about supervisions with staff, not as about monitoring how they're doing in the last month or so, but to actually engage with their team members and ask them where they want to be in 5 or 10 years' time. Don't ask them where they want to be in 2 years' time, because everybody will say to you, I want to be in this organization in a more senior role, because they think it feels somehow disloyal to say anything different. But if you say in 5 or 10 years, they'll feel much more comfortable to be a lot more honest. And as soon as that line manager knows some career aspirations of their member of staff, that is gold dust, because they can then start factoring in the role they're in right now as an active part of their career journey. And you can do that by letting them maybe work every now and again in other departments to give them different experience. And that is wonderful for them because you're looking after their career, but brilliant for you because it breaks down silos and it helps you share more information. So it mitigates against you losing information when people leave. Breaking down silos is a real passion of mine and it works really, really effectively. Also, maybe the line manager could match them up with somebody relevant in their network as a mentor for that role they want to move to, or maybe within the hospice sector, which is where you could all work so much better. I mean, the gold dust of the hospice sector, where you've got similar organizations, share best practice between people doing similar roles, is wonderful, and you should all grab onto it with both hands and encourage your staff to become trusted. And probably most of your charity boards don't have one member with any charity sector experience on them. So, and I think that's one of the root causes of a lot of the problems in our sector, from diversity to flexibility, all of those things. So if you encourage your staff to become trustees, then they will get brilliant experience. It'll really benefit your organization, that experience, and you'll be engaging with helping them to develop. And then coming back to that flexibility and trust piece, the organizations that I know who have the best staff retention are often the ones who have the most flexibility and trust within the organization. And once your staff have that and have that engagement with your culture, it can be really hard for them to find similar elsewhere. So that pay rise they could get by leaving your organization becomes far less attractive, because they don't just want the pay, they want the culture, they want the flexibility, and it's not worth them sacrificing their quality of life just for a few £1,000s more. And do remember that in your organization, probably in all of your organizations, it's likely you've got at least one person in the organization who has retention in their job description, but about donors rather than about staff. But all of the things that all the skills you need to use are pretty much exactly the same. It's just about engagement and connection. And you can engage with your staff and thank them and connect them to the cause. I mean, we all tell our supporters how their £10 per month makes a difference. But do we ever tell staff members that, about how their 37 hours per week makes a difference? If you do that and engage with those staff and make sure they feel connected and give them that flexibility and trust, they will stay far longer than they do. It's such a small thing in a way, but makes a massive difference. And if you do all these things and keep them engaged and happy, don't hide it, use it. Get the retention stats when they've improved into your job packs. Get your amazing culture into your adverts. Get your staff to talk on social media about how wonderful it is to work at your organization. And if you do all of this, then maybe new staff will start to seek you out rather than you always having to go out and find them yourselves when you're recruiting. So as I said, that is all very top line of the things you can do. I love helping organizations to do this kind of thing because recruiting first time and holding on to your best staff, as I say, is generally free and easy, and using the skills you have yourself as a job seeker and that you have in-house when you're thinking about how to keep your supporters on board. And once you get it right, it can genuinely be a lot of fun. Thank you so much. I still can't hear the auditorium though, Rowena, sorry.
Paul, thank you so much, and thank you for being so patient with us as we try to sort our technical issues. I'm always struck by when you speak about some of the small tweaks that you can make that make a massive difference. And I was also struck about some of the similarities with what you were saying, Paula, particularly around training, listening to people, but also that placement and rotation and that experience. So I was really struck with that it's not just about the clinicians or doctors. This will cut across all professions in our sector. So yeah. I'm going to sort of move straight on to Vanessa if she's there, because I want to make sure that we've got enough time for all the presentations. So if Vanessa's there, oh God, please let this work a second time. So is Vanessa there?
Hello, can you hear me?
This is not looking good.
Can you hear me?
There she is. Excellent. Vanessa, over to you.
Can you see my screen as well? I'm just trying, there we go. Can you see that? Just wave your arms if you can see it and hear me. Excellent. Oh, fantastic. Thank you. It's great to be here. Thanks for the invitation to contribute today to the session. And I'm going to try and fit in 3 initiatives that I'm involved in nationally and regionally to support recruitment, retention, and the development of palliative and end-of-life care workforce. And hopefully we'll see all the connections from our talks today, which have been fascinating. So looking forward to hearing questions at the end. So the 3 initiatives that I'm going to focus on do focus on the nursing and the allied health professions workforce for palliative and end-of-life care. The first one is a national project with NHS England developing what's called a qualification in specialty for palliative and end-of-life care. The second one is just an update on the work with Health Education England Centre for Advancing Practice on the development of a palliative and end-of-life care credential. And the third one is a regional project for North Eastern Yorkshire, which has the potential to become a national project or certainly transfer to other regions around the development of the CNS workforce. So the first one, it started in 2021 and it has expanded from its original remit. The original proposal for the qualification in specialty from NHS England did just focus on registered nurses providing general and specialist palliative care, but we have extended the proposal, which I'll explain in a moment. The original proposal was around developing the level of knowledge and capability of those who provide general and specialist palliative care and ensuring access to education and learning and development opportunities for both the future and the existing workforce. And in the original plan, we were focused around developing 2 modules which were proposed to set this minimum standard of knowledge and skill for the workforce. A foundations in palliative and end-of-life care for pre-registration students and the unregistered health and care workforce, and a fundamentals in palliative and end-of-life care module for the registered level workforce. I've used the word module there, but I'd like to explain that this really was just a framework for offering learning outcomes and a syllabus for the core knowledge that we anticipated the workforce would need to be able to provide both general and specialist palliative and end-of-life care, and to offer some guidance for assessment. And that development could be through an academic module, but also emphasising the importance of workplace-based learning, the use of e-learning, and a whole range of CPD opportunities. So not just necessarily an academic award. But as I say, the project has grown slightly, and we've now got an extended proposal, which probably fits in with much of what Paula and Paul have talked about in developing a career pathway and core capabilities in practice with an aligned education framework for palliative and end-of-life care workforce, both the generalist and the specialist workforce, creating an end-to-end career pathway depending on the aspirations of those who want to move into specialist palliative care, but also making sure that there's an aligned education framework which is commissioned and available to make sure that education and learning and developments are available for the opportunities to progress throughout someone's career as well. So there are 3 parts to the proposed framework, which include the career pathway. I'll talk a little bit more about them, the core palliative and end-of-life capabilities in practice, and the aligned education framework as well. So what we're focusing on in the career pathway is levels of practice, not specific roles. And the work now includes both nursing and allied health professions. The levels of practice that we're focusing on include the supportive, assistive, pre-registration, registration, enhanced, advanced, and consultant level practice. So we're drawing in work, national work around career pathways, but also the work that the Centre for Advancing Practice are working on for the advanced and consultant level practice. So trying to put all the pieces of the jigsaw together of the work that's going on nationally around career pathways. The core capabilities in practice are workplace-based knowledge and skills, and these are aligned to each of the different levels of practice in the career pathway, and also represent the 4 pillars of professional practice. And I think Paula mentioned these: the clinical, the education, the leadership, and the research expectations of practitioners in their everyday roles. The education framework that underpins all of this makes sure that we can align the knowledge and skill outcomes, the learning outcomes, the syllabus, and the recommended assessment for each level of practice. And as I say, aligned to national frameworks for advanced and consultant level practice for the nursing and allied health profession workforce. Again, it's presented in module format, but as you can see in the parenthesis, that this is about just a framework for offering learning outcomes, doesn't necessarily mean an academic award. Although these things, if they are within a higher education institution, can be then added together to create a course such as a postgraduate certificate or diploma, depending on the expectations of the individual practitioner or their employer for some additional learning. I'll talk a little bit more about the credential for palliative and end-of-life care in a moment. So in pictorial form, this represents all of the things that bring together the career pathway, the core capabilities, and the education framework. You can see it focuses on that general and specialist palliative and end-of-life care workforce, bringing together the 4 pillars of professional practice and the different levels at which the career pathway offers that route through, and also identifying and reinforcing the learning and development can be through a range of learning opportunities, not just through academic award. The core capabilities that we're focusing on include these key aspects of palliative and end-of-life care, and they will develop, deepen and build the knowledge and skills of the practitioner as they progress along the career pathway, with a shifting focus from individual patient care through to service for a group of patients and families, through to organisation and system level practice. In addition to that, this is a bit of a busy slide, apologies for that. It's the education framework. You can see the 2 modules that were originally proposed included here as core modules, and then the opportunity to add to these with some additional learning relevant to somebody's role or their employer needs, to build up in a flexible way a framework for education relevant to that particular practitioner or employer, and to help them to advance and develop to meet their particular career aspirations. And this diagram really just reinforces that. You can see the first column for the registered practitioner, the core module, and then the next level up, the enhanced practitioner, adding in perhaps some specific learning around communication skills or psychological support, and then starting at the advanced and consultant level, meeting the HEE Centre for Advancing Practice requirements for advanced practice, plus the credential for palliative and end-of-life care at both the advanced level and consultant level practice. So really that flexible framework, building that career pathway, and hopefully supporting recruitment and retention into the workforce. So where we're at now with this particular project is, some of you may have contributed to a survey that was distributed over the summer establishing demand. So thank you if you did. We're currently looking through that feedback. We're working with the commissioning process at NHS England to develop the commissioning process for these modules and this career pathway and the education framework, and also starting to review the career pathway, core capabilities and education framework to go out to wider consultation. So please do have a look out for that, and we very much welcome your feedback and comments in the future. The second part of the work is the credential for the advanced practitioner in palliative and end-of-life care. This work took place during 2019 to 21, and we had an open consultation and received lots of feedback from practitioners, both specialists, generalists, and also from families, patients, carers, which was really helpful in developing the credential, which identifies area-specific knowledge and capabilities in palliative and end-of-life care for the advanced level practitioner, both nursing and allied health professions. And these are achieved in addition to the generic capabilities that the centre sets out for anyone practicing at an advanced level. And from June 2022, the credential was approved, and we're currently waiting for that to be published, and we'll be developing a communication and implementation plan with the Centre for Advancing Practice in the next few months. So please have a look out for that. The credential itself includes lots of information, including a curriculum and the capabilities in practice, but it also includes guidance around workplace-based supervision and assessment, and for the practitioners to record their information in a practice portfolio and what criteria they need to meet to complete their training and be recognised as an advanced practitioner in palliative and end-of-life care through the Centre for Advancing Practice. Someone can achieve that status of advanced practitioner in palliative and end-of-life care through 3 main routes. One is through undertaking the MSc in advanced practice and the generic capabilities, and then the palliative and end-of-life care capabilities after that. Or they can undertake a programme where the palliative and end-of-life care pathway is incorporated within an MSc of advanced practice, or there is a separate portfolio of evidence route. And all the information will be available on the Centre's website once the credential is published. The final project, conscious of time, is the focus of the developing the specialist palliative care CNS workforce. This is originally a regional project for the northeastern Yorkshire, and as I say, has the potential to extend beyond that nationally to address some of the recruitment and retention challenges that some of you are probably familiar with in recruiting to CNS posts. And this was something that brought together the specialist palliative care services initially across West Yorkshire, coming together to address the challenges where they were all individually trying to provide training programs, around induction for CNSs, and which was taking a considerable amount of time and pressure on the current workforce. And also when people moved around different services, they were undergoing the same programme in a different organisation. They also realised that access to specialist education and training for the new CNSs was very limited and often cost prohibitive for the charitable sector. So, drawing on the word, I think it was Paula and Paul talked about the opportunity for collaboration. The services did work together across West Yorkshire and now across northeastern Yorkshire to create a collaborative programme for the development of clinical nurse specialists, newly appointed within the first 2 years, and secured some funding from Health Education England to pilot that. The programme is for new CNSs and also and involves using the ECHO platform to offer a series of learning opportunities and a practice portfolio of evidence for the new CNSs. So what they've achieved, or what the aims were around a competency document, the development of an e-portfolio, and to increase, all aimed at increasing the confidence, knowledge and retention of the staff, but also an e-portfolio that was portable, a passport between the different organisations and services for that collaboration and drawing on the expertise of the individual services. The competencies bring together those 4 levels of professional practice again, so there are outcomes associated with clinical practice, leadership, education and research, and identifies very clearly those expectations of new CNSs at 3, 6, 12 and 24 months onwards, with a supportive education programme of 6 sessions that the CNS and their mentor participates in over a period of time. And the pilot involved a number of CNSs that actually represented a third of the workforce across West Yorkshire to start with, and they were able to evidence their achievements in a core competency and portfolio document. The CNSs identified some key learning that they wanted to achieve during the echo sessions, and these are some examples of those. And each session was facilitated by a topic expert and an interactive case-based discussion, which the CNS participants actually undertook themselves. And then there were mentor sessions to support them. So evaluation has been key throughout all of this, and we do that in a number of ways at the start and at the end to assess the competency, knowledge, but also the ongoing achievement of the CNSs at 6 months post the actual development programme. And we receive feedback from those who've withdrawn, although there's been very few, and there are quick polls at the end of each of the sessions. So we've got a range of evaluation data, which has all been very positive from the actual participants. I'm conscious of time, so I'm going to leap forward and talk about the value for money, the outcomes. This is very cost effective compared to accredited programs, and demonstrates the importance of sharing resources across different organisations and services, and has supported the practitioners to produce evidence for their portfolios, professional development plans, and be clear about their career aspirations. I'll move forward. We did create an e-portfolio, which I'm happy to share links to for colleagues who are interested. But I suppose the main outcomes and recommendations are that we're now on the third delivery of this. We've got funding secured for the 4th and 5th programmes, and we want to create some specific programmes for children and young people's palliative care specialists, and also use the delivery model for other levels of practice as well. So it's opportunities to enhance and adapt the programme and its methods. The final thing I'd like to say is to send my very best wishes to the team who have been, are now finalists for the Nursing Times Workforce Awards and are at the Hilton today, hopefully fingers crossed, for that award this evening. However, they've achieved enormous work, regardless of whether they win or not as finalists. So I'd like to thank you and hope that it's been very helpful to share some of these national and regional initiatives. More than happy for people to email and to discuss them all in more detail in how we're supporting recruitment and retention in palliative and end-of-life care. So thank you.
Vanessa, thank you very much. Fingers crossed for your team for later today. I think we're running out of time in terms of questions, but if there are any questions, please do put them in Slido with the few minutes that we've got left. I think what I'm hearing from all of our presenters, both the small tweaks across recruitment that you can make in that bigger picture, as well as the more structured programs around particular specialisms, is the need for us to demonstrate the value of our staff, to look at new ways of building experience and engagement across organisation, but externally, and collaborate together around that so that we make ourselves the employers of choice and we retain our value of our staff teams. So that's what I seem to have been hearing from all of our presenters and all of the things that we've heard this afternoon. So I think, unless anybody's got any burning questions, I can't see anything on Slido. I can't see any hands up. I don't know whether there's anything any of our speakers wish to say as a final summing up of anything. If not, then I think I would just like to round up and say thank you very much. Thank you to Paula for your presentation, but also stepping in and saving me from dying on stage. That was brilliant. Thank you to Vanessa and Paul for joining us and persevering with that. It was amazing to hear from you in the end, and I apologise for the technical issues we experienced. So thank you both very much. And thank you for everybody here for bearing with us on that, and hope that you found something interesting in the presentations, and coffee awaits you. Thank you.
Thank you.
Thanks.
If I then go to the master, test, 1, 2. Right, so on A, test, 1, 2. So that's me headset working. Oh, you coughed.
I did. I can hear you.
Right.
I can hear you. Am I coming in?
Yeah.
Cool.
Right.
Are you guys okay? Are you going to work through a reset again?
Yeah, we're just going to be
trying it.
Okay,
I can hear you.
I'll leave you in the room then. Okay.
Yep. Thank you.
Bye.
Cool. I'm going to go out because it's picking up my phone.
Yeah. And
Right.
then I'll mute the headset.
Cool, right. Well, there's a lot of noise out here. Hey, Sharon. You alright? So, can you hear me? Hello?
Yes, we can hear you, but give me a second. I'm just going to try and get a handheld. Just check.
No worries,
it
I'm just going to keep talking nonsense while waiting. Check, 1, 2. Hey, 1, 2. The arsonist had oddly shaped feet. Check, 1, 2. 1, 2. 1, 2. Oh, I need to cough, sorry. Excuse me. Sorry about that. All good. Check. 1, 2. Hey, 1, 2. Check. 1, 2. Hey, 1, 2. Check. How's it going? Can you hear me? Looks like there's still a few people in the auditorium. If that makes a difference.
Can you hear
Oh,
me?
I heard the Yes, I hear you.
Right,
I hear
can
you
hear
now.
me absolutely okay?
Yes, there is no feedback loop or anything like that.
Right, we're not in the room yet. I don't know if the room's still busy, but hold on.
There's still a couple of people there.
Sorry. No, there's still quite a lot of people in the auditorium. Oh, they're coming in for the next session.
Wow, they're early.
Yeah.
You want to just push through anyway?
You
Just to do a quick check. I'll just say test 1 2.
Are
Check
you happy
check.
with this?
1 2.
That'll be
Check
all
check.
right when it goes in the room.
Are you talking to me or are you talking to?
No, I'm talking to James. Sorry, Stuart.
Okay, cool.
Right, just
Hey,
do
hey.
a count to 5 then. Don't let anyone swear next to you.
Goes 1 2 3 4
And that's
5.
okay with me coming through as well. Right, we're all good. We're all good, Stuart.
Wait, are we good? Are we happy?
What? Is that what you said? Sorry, I didn't hear. Yeah, we're all good.
Is that working?
Yeah.
Can you let me know you when you find it hard to speak? Can you let me hold you? I cannot breathe. I cannot leave. I'm in this too. Don't tell me lies, I need your truth. My mind's at stake. Lay side by side, we lie awake. And I don't care if you don't wanna talk no more. I'll force your hand. Just let me know where we both stand. Can I find what's underneath? Won't you let me know you? Break me down and watch me bleed. I just need a moment. I cannot breathe. I cannot leave. I'm in this too. Don't tell me lies, I need your truth. My mind's at stake. Lay side by side, we lie awake. And I don't care if you don't wanna talk no more. I'll force your hand. Just let me know where we both stand. And I'm just wanting you to hold me. And I'm just wanting you to hold me. And I don't care if you don't wanna talk no more. I'll force your hand. Just let me know where we both stand. talk to me. You're good at it, so good at it. You're too close to me, and I can't think straight. Swear that I was mad about something, but I can't remember what. I swear that I was calling you to break things off, but it's so cloudy. Ooh, I'd be.
giving up, trying to mend a broken heart. It's time to let each other go. Now we know. One day, baby, we'll be okay, carrying the love we lost to life. Someday we will find our own way, cover up the heartache deep inside. One day, baby, we'll be okay, carrying the love we lost to life. Someday we will find our own way, cover up the heartache deep inside. Sharpen knives, make cleaner cuts. We are blunt, not to give up. We lost our way too long ago. Now we know. One day, baby, we'll be okay, carrying the love we lost to life. Someday we will find our own way, cover up the heartache deep inside. One day, baby, we'll be okay, carrying the love we lost to life. Someday we will find our own way, cover up the heartache deep inside.
Hello. I'm just so pleased to see so many of you here. Thanks so much for coming. Those who are here in the room, those who are online. Last year, I think we had a really fantastic presentation actually on end-of-life care in prisons, but there was just one in the whole conference. I'm absolutely delighted today to have a whole session on it. It's a really important topic, and we've got some really great speakers coming up. Just a few small housekeeping bits. Recordings of this session will be available 10 days in 10 days' time on the new online platform. If you're watching online and if you're in the room, you'll have seen this morning, you can use Slido to ask questions. Please use that if possible. It just gives an opportunity for us to make sure that both those watching at home and those are here, their questions are prioritised. And yeah, also try and keep your phones on silent. And also, you've probably already heard this a lot today, but in case of emergency, everyone will be asked to evacuate the venue and go to the nearest available exit. The muster point is between the SEC Centre and the SEC Armadillo. So, welcome to the session on death and dying in prisons. Today, we'll be hearing from Marion Grant, Community Partnership Development Manager at St Giles Hospice, and Suzanne MacArthur, Head of Community Development and Partnerships at the Hospice Charity Partnership. Really excited to see them here today because I've been seeing their journey as they set up a bereavement support service pilot in HMP Birmingham. We'll hear them talk about that shortly. Then I'll be giving kind of a brief introduction to the topic and some of the work that's taking place at a national level on this issue. And then finally, we'll be hearing from Annalise Matthews, locum consultant in palliative care at Pembridge Hospice and palliative care team, and consultant in palliative medicine at HMP Littlehay. Maria O'Neill, palliative nurse specialist at Northamptonshire Healthcare NHS Foundation Trust, and also a Queen's nurse, and Danny Newland, family liaison officer at HMP Littlehay. And they'll be talking about their work caring for people who are dying in HMP Littlehay and the innovative practice that they've developed there. So, without further ado, Suzanne and Marianne, could you come up here, please? If everyone will join me in welcoming our first presenters.
I'm a lady of a certain age, so I need to put my glasses on now. Hi, everybody. I'm Suzanne MacArthur. I'm the Head of Community Development and Partnerships at the Hospice Charity Partnership in Birmingham. My role within community development is working with those marginalised groups across Birmingham and Sandwell to look at those barriers that currently exist to them accessing palliative care, end-of-life care and bereavement support, and working with them to address those inequalities and working with organisations within those communities to develop partnerships to really build the capacity and resilience within communities to care for each other, and obviously encourage conversations about death, dying, loss and grief.
Hi everyone, my name is Marianne Grant. I'm also a Community Partnership Development Manager. I come from St Giles Hospice in Lichfield, covering quite a vast area across Staffordshire, but also parts of the West Midlands. Very similar to Suzanne, my role covers working around communities, supporting and developing them to be more resilient, encouraging conversations around death, dying, with a big focus around bereavement as well. And obviously one of the big areas for us is about addressing inequalities of care.
So we know that loss and grief are universal experiences, and they're not restricted to specific societal groups. However, it's well documented in research, and you'll hear more about this later, that actually prisoners they deal with a lot more complex grief, and the frequency of their loss and grief is a lot higher than the general population as well. The ambitions for palliative and end-of-life care states that bereaved people in the general population often feel disconnected and isolated when going through loss and grief. And this isolation is really, really exaggerated within the prison environment, purely due to the vulnerability of the prisoners, the need to protect themselves, and being in a male-dominant environment. In 2020, Hospice UK produced the Dying Behind Bars report, and it identified huge inequalities that currently exist for prison inmates accessing palliative end-of-life care and bereavement support. And they did a really good job of actually identifying how hospices can work in partnerships with prisons to try and address some of these inequalities. As you all know, and I'm telling you what you already know, the Ambitions for Palliative Care Framework Standard 6 says that every community is prepared to help. So what Marianne and I wanted to do as a collaborative project was work with HMP Birmingham to actually pilot whether we could adopt a community development model within the prison environment, to co-design a programme whereby the prisoners would design with us and develop the skills to be able to support each other during loss and grief. So the aims of the pilot project were to develop and pilot a community development bereavement support model for residents at HMP Birmingham and the prison staff. We wanted to work as a collaborative of 2 independent hospices. We wanted to increase the capacity and the resources of the staff at HMP Birmingham to support the inmates and each other. We wanted to upskill a cohort of volunteers that were prisoners at HMP Birmingham to support each other in loss and grief. We wanted to increase the reach of our community development work because we haven't really done a lot of work within prisons, and to be able to roll out this model to other prisons within the West Midlands. And we also wanted to provide tools and resources for the prisoners and the staff to be able to support their family and their peers in loss and grief. So the process that we used, the key factor for us was obviously getting the buy-in from the prison governor. Without the buy-in, it's just a no-go. So we met with the governor and presented the research findings, the standards from the Ambitions for Palliative Care Framework, and we were really fortunate that we got 100% buy-in from him from the word go. He was really, really keen for us to be able to work with the prison to try and address some of the problems. And I think post-COVID, that had really helped because he'd seen firsthand the impact that COVID and bereavement had had on the inmates. We were really fortunate that at HMP Birmingham, they also have a group of prisoners that are already volunteers called Health and Wellbeing Navigators that have been upskilled to support their peers in health and wellbeing. So they've already had some basic mental health first aid training and suicide prevention training. So for us, this was adding another tool to their toolkit to be able to support their peers in loss and grief. So we were introduced to 6 of the 18, I think it was 18, 16 or 18 health and wellbeing navigators. And we sat with the 6 and explored with them what our offer was going to be. We gave them our proposal of, we think this is going to work, developing a community development model within the prison, and what are your thoughts? Do you think this is going to work? And it was like, yeah, this 100% buy-in from them. Very much, one of them said, thank goodness something's being done about it. So we used a selection of case studies, personal lived experiences, and a consultation to actually develop with them a programme to upskill them. From the case studies and the questionnaires that we gave and the personal lived experience, let me move that on, 83% of the prisoners reported that they would have been better supported if they'd had fellow trained prisoner to talk to about grief without the fear of being judged. So for them, it was really important to have a peer that they knew had been trained that was a safe person to go to, and that would have made a huge difference to them. 67% of the prisoners felt that by having a better understanding of how grief affects people, it would have helped them to have dealt with the emotions and the experiences that they were going through while they were going through grief. And some of the feedback that we got as well, the statements were, the fights that you have to go through are just not fair.
and that was around going and visiting loved ones who are in the last days or hours of life, and being able to attend funerals of loved ones. I'll go on about that a little bit more. One said, "I'm so glad we're doing something about it." And there was one gentleman who, you know, I will never forget it. You know, his simple thing of saying, "I've got 2 sympathy cards in my cell and I don't know what to write on them and they're still there, simply because I don't know what to say." And it was just something as simple as that that was going to be so important to him. So the themes of the case studies were very much emotion-based. There was a huge amount of frustration from the inmates about the fights for basic rights, of being able to say goodbye to their loved ones, being able to attend funerals, and the sheer lack of support that was available to them for bereavement support. The chaplaincy team were the key support mechanism, and it was at very minimal level, and very few managed to get to have one-to-one counselling. Anxiety really came through about dealing with feelings and expressions that they weren't used to, really unfamiliar emotions, and having to deal with those in a threatening environment. There was a huge sense of hopelessness and helplessness for not being there to support their families on the outside. And for them, there was that huge sense of guilt of not being able to provide that support for their loved ones. There was, not surprisingly, a huge bottle up of emotions, and, you know, they were openly, you know, saying that actually, because of this, we're turning to drugs. So we shared the key learning outcomes with the 6 health wellbeing navigators, and the discussions progressed on to how the wellbeing navigators thought the programme could be developed. And we discussed the key themes that they thought that they should be included in the programme. So the key topics they identified were they wanted tools to help with that sense of hopelessness, of being able to support their peers and their loved ones. They wanted to be able to feel confident in knowing what to say and what not to say to somebody who was going through grief and loss. They specifically asked for some more information around bereavement through suicide, because peers within the prison were, there was a higher rate of suicide within the prison and having to deal with that. They wanted resources that they could share. They also specifically asked for support around supporting peers who were grieving the loss of a child. And they were very aware and sensitive to the range of culture and diversity within the prison and the importance of taking that into account. The additional information which we thought we wanted included in it was a little bit more about the background evidence of why it was so important for the training to happen. We wanted to let them know a little bit more about disenfranchised grief and how that can affect inmates. None of them really knew about pre-bereavement, and so we wanted to introduce that and the importance of that within the grief process, and more importantly, around self-awareness and self-care. So following the meeting and them telling us what they wanted, we went and sought some extra guidance from organisations that we'd worked with previously, specifically around bereavement through suicide and grieving with loss of a child. So information was kindly provided by survivors of bereavement by suicide and a child of mine, and that was incorporated into the training programme. And then we got all the programme together, and then we started delivering the programme to the Health and Wellbeing Navigators. I'm going to hand you over to Marianne.
Thank you. So moving on to the actual training programme then. So from all the co-design work that was delivered, we focused on initially just to try and give a bit of context with regards to hospice care and what we're about, but also as well our role of community development workers. And this was a real opportunity for us to really start to raise a little bit more awareness about hospice care, but also as well the work that we do within the community to engage with hard to reach groups and communities that have historically been excluded. We wanted to ensure that we provided the health and wellbeing navigators the opportunity to understand a little bit more around the skills needed to support someone with a bereavement. So we delivered our Understanding Bereavement workshop, which we both as organisations have delivered, within our communities, and we just felt it was something that could be adapted to sit within the prison setting. This was an opportunity for us to really focus around looking at the impacts of loss and grief, and actually how the prisoners are able to support one another around people who are affected, and able to maybe as well to have some of the difficult conversations as well that were needed. And also as well to give them an opportunity of accessing tools and resources to share with one another. One of our key aims that we wanted to try and achieve within the prison was to set up a bereavement help point. And these are something that already we know are successful out in the community. And we were quite determined to actually set this up as a bit of a legacy after we delivered this training. So we delivered some training around of actually facilitating and running their own help point, but giving them some of the communication skills. And exactly what Suzanne just mentioned there, with the focus around about their own self-care when actually dealing with loss and grief on a day-to-day basis. We delivered the sessions as a part of a training programme to 15 health and wellbeing navigators. We did it actually across 2 separate groups. I think on average was around about 5 or 6 within a group, and that was a really good opportunity for us to share some people's own experiences within prison of losing a loved one, or even actually trying to have conversations and supporting fellow inmates around this. We also engaged at this point actually in the training. We had the service user involvement manager at the prison, but also the prison chaplain, which was key for us to start this conversation and deliver the training. So as part of the training, we felt it was really important that we captured some really learning outcomes from the training that we delivered. And what we found at the beginning, we did a measurement of actually how they felt, of their confidence with being able to talk to fellow inmates who are dealing with loss and grief. And we had quite a bit of a mixed level of confidence within the group, but we had probably a little bit more people feeling a little bit more, less confident as such to start supporting one another around loss and grief. Once we completed the training, we tested again just to see how they felt with the information they'd been provided and the conversations they heard, and we saw quite a bit of a growth with regards to their confidence in this subject matter, which for some of them was really, really difficult. The confidence that we tended to see for a lot of the prisoners was actually more opportunity to actually not turn their back to maybe other prisoners that are experiencing loss and grief, and to become actually a visual presence within the prison and within their wings to be that place of support, and actually being quite proud as well that they were providing this support to fellow prisoners. So, as we always find with any project, there is always challenges, and I wouldn't say we had quite a few of those along the way. Being a new project, we'd never delivered this community engagement work in such a setting like a prison. And we just wanted to sort of highlight to some of the key points to you what we found with delivering a project of this type. The big one for us that we identified was staffing and resources within the prison. Like Suzanne said, we had an amazing buy-in from the governor at the beginning and was very, very supportive of this. But for anyone that obviously knows the prison sector, there's quite a lot of pressures that are happening for them at the moment, and staffing is a huge issue. So when you're trying to come in and actually deliver workshops and training with people, that can actually be quite a difficulty or a big ask to release staff to help actually physically move prisoners to a training area. This obviously impacted some of the delivery of our programme, and we had to, as trainers, we had to be quite flexible within that. And actually some of the days wasn't a set standard of how our normal training would go. We also had delays in developing the bereavement help point after we delivered the training, because the health and wellbeing navigators were really, really keen to get going and actually put their skills to use. But obviously, that doesn't just happen with them just doing it. So we needed to ensure that they had the right resources, but also the buy-in as well, and enabling them to come together as a group to support one another. We also had issues around the prison security systems, trying to take in training materials into a prison setting. I never quite realised how hard it would be. So paperwork, leaflets, information, we just couldn't take all of that in. So we had to try and find other ways of doing that, and having, thankfully, some real key people within the prison that were able to print information off for us. Also as well, the big problems that we have around is their lockdown systems. We were really restricted with a strict time limit that we could provide the training to the prisoners. So we were very mindful, and it was quite a bit of clock watching during the day. I would also say the support and buy-in, it wasn't just issues that we were faced with from the actual prison. We actually have faced this across within our own hospices, or within our areas and the areas that we're working with. Obviously, as you can understand, doing any work within prisons can bring about a lot of sensitivity. I think from some of the other sessions we've spoken about some of the barriers that we know that people experience, and when we try to engage with community groups that historically have been excluded, there are some issues around how do we publicise, how do we communicate the work that we're doing without causing any fallback from supporters and donors. We also had some staff as well questioning with regards to why we were doing this piece of work within the prisons. So there was actually internal work we had to do around education and awareness, and actually the importance. So whilst we're providing wonderful palliative and end-of-life care, there was no recognition actually we need to be actually providing the bereavement support as well. And then we also had to really rely on goodwill of one member within the prison, and we wouldn't have been able to deliver this project without the one officer who actually physically moved us around the building, but also brought the prisoners to us. So there are some challenges, guys. I want to sort of give credit as well to the chaplain. The chaplaincy team on the whole within the prison have been key and instrumental with trying to help support this initiative, but also as well their input and actually being able to influence this has been one of the key priorities for them moving forward. And actually we've got some testimonies that we received from the chaplain, and their feelings around the programme that we delivered was an excellent initiative, which clearly showed empowerment for the prisoners to be able to help and support one another. And also then the one key strand that kept coming out was actually a greater sense of community and a supportive fellowship. And I think we saw that in bucket loads with regards to the chaplaincy team, and actually how the prisoners worked alongside them as they were their support night and day and when issues were recurring. The next slide is from Trevor, who has been our little icon really with regards to helping us deliver this project. And Trevor has been key in helping us deliver the project. And for his perspective, he found the project was a huge benefit. And we've just got a very short clip that I want to show you that he kindly recorded for us for today.
3 years ago, we devised a peer support service, working with prisoners so they can go out and support their peers across the wings with a whole range of different issues that arise in the setting. Incorporating the bereavement training into that process has been a real positive exercise. It's given the confidence to the WBNs to go out and sort of tackle this subject, which is a difficult matter for anybody really, to be honest. Across the board, whether that's staff or prisoners, to approach and feel confident in talking about these things. The WBNs aim to be non-judgmental and be available for people at any time really. so they can help resolve their issues. They've got that instant connection from a peer perspective where people won't talk to an authority figure, they'll speak to a peer really and explore their problems. So I mean, loss of liberty, loss of control, and incorporating bereavement into that setting can be extremely stressful for people. So they're there to help people really, help them to help themselves, and in turn they may go on to help others once they start their recovery journey. As the great Antarctic explorer Ernest Shackleton stated in 1914, by endurance we conquer. In this setting, it is about endurance and resolving those issues wherever possible. And attending this training has enabled the WBNs to do that really, and sort of support people through an awful lot of distress and getting them back onto the right path where they may be able to help other people in a similar position themselves at a later date.
So I'm not quite sure whether that is quite hard to understand because of the volume and the muffled, or actually Trevor's wonderful, strong West Midlands accent. So, but what we wanted to really sort of highlight to you really for this project, our sort of final words around doing it has been one of the most rewarding and insightful projects I think I've actually probably been involved in for some time. Seeing the enthusiasm of the prisoners and actually being privileged to actually be there as part of supporting them and giving them the skills and training has not only given us an opportunity to understand about how these are communities that need to be supported by us, but actually to give them the skills to actually take back out into their communities after they have served their time. The project has demonstrated to us as a community development approach, this can work. And we are very, very keen to see that we can continue and extend this model across other prisons within our delivery area. We do recognise that there's quite a lot more work to be done, not just for us as hospices, but also as well as an opportunity to collaborate and to make sure that we can do this with other hospices within the area. And we are desperately trying to look at ways that we can maybe secure some funding to actually develop tools that can be used as part of working collaboratively between hospices and prisons. So we're hoping this won't be the last, and that we will continue this project on, as we do recognise that it's something that has to continue. And we'd welcome any opportunity as well of anyone that might be interested to find out a little bit more and how we can maybe support this within your own areas. Thank you very much.
Unfortunately, Marianne and Suzanne's plane has been brought forward, so they're not going to be able to answer questions today. But if you have questions for them, please feel free to still put them in the Slido, because we'll capture that and send them off to them. And also, if you want to get in touch with me or anyone at Hospice UK, we can forward your questions to Marianne and Suzanne as well. No, I think I'm missing. Oh, there we go. Right, so I don't know how I follow that, but I just thought I'd introduce a little bit of the topic of palliative and end-of-life care in prisons, some of the work that Hospice UK has been doing, and also the other work that's going on at a national level. This work is part of our organisational goal, like the sector as well, to tackle inequity and widen access to hospice care. People in prison are known as an inclusion health group, and that means that they face the sharpest edge of exclusion and marginalisation. People in prison have often experienced trauma, poverty, domestic violence, and other such issues, and these experiences are compounded by the barriers they often face in accessing health and care, which can lead to deterioration in their health. In fact, when looking at older people in prison, in the general population, we tend to say that an older person is over 60, whereas in prison, we say over 50, because of the impacts of the experiences they've had and of being in prison, that category of what makes someone older in terms of their health outcomes is much lower. However, I mean, being deprived of your liberty doesn't change your right to health and care. So people in prison have a right to the same provision and access to appropriate health and care services that are consistent in terms of range and quality with those in the community. So it's really important that we ensure that they have the same access to health and care as everyone else. However, unfortunately, this isn't the case. So people in prison across the UK very often don't receive the care and support they need at end of life. The speakers here today show really fantastic examples of work going on. So Suzanne and Marianne on bereavement support, and we're going to hear from Maria, Annalisa and Danny on palliative and end-of-life care, but this is not consistent across the UK or indeed England and Wales. The Dying Behind Bars report that was mentioned earlier, as part of that, a member of our team conducted analysis of fatal incident reports from the Prison and Probation Ombudsman, and that revealed examples of inappropriate use of restraints on people at end of life, inequivalent care of what they would receive in the community, delayed or often no consideration of whether they'd be eligible for compassionate relief when they were imminently at end of life, and a lack of bereavement support. Although I would caveat this last one, because it's where bereavement support was explicitly mentioned. And as Suzanne and Marianne mentioned, chaplaincy is a huge part of what life in prison is about. And I think often there'll be cases where there is bereavement support being provided by a chaplain, and I've had many conversations around that support not being sufficient in terms of chaplains being very stretched and there being a need for further bereavement support because of the complex bereavement needs that people in prison are likely to have. But I suspect that this data, because it's looking for explicit reference to bereavement support, might miss that chaplaincy support. So, in addition to people in prison already not receiving having poorer health and care outcomes than people in the general population, often not receiving the care and support they need, the number of people in prison who are older is also increasing. So the number of people in prison, as you can see, over 60 has more than tripled in the past 20 years. This is a result of harsher sentencing practices, so people being placed in prison with an increase in the number of sentences, but also an increase of the length of that sentences. And also as a result of a rise in convictions for sexual offences, including historic sexual offences convictions. It's also caused by a lack of a transparent and timely compassionate release process. As a result, in the past decade, deaths due to natural causes in prisons in England and Wales have increased by 77%. So this is not just, well, not just, I don't know how to phrase it like that. There is an inequity in terms of the access to care that people in prison have, and not only that, the number of people experiencing that inequity is increasing. As I've said there, it's led to an increased need for palliative and end-of-life care support. So, people are noticing this. So, as part of the report we released, Dying Behind Bars, we did a survey of hospices in England, and this is just before the report came out in 2021. So, it's a little bit out of date. I mean, Marianne and Suzanne's work wouldn't have been picked up by this because that was inspired by the report itself. But at the time, 25 hospices in England, so 15%, were working with prisons in their local area. 65% of that support was on-demand end-of-life care to prisons, so being a person to call when a prison might have a concern about someone who's dying in their care, providing that ad hoc advice. 62% was direct clinical care, so going into prisons and providing that palliative and end-of-life care support. And 54% was providing teaching and education to prison staff, operational staff and healthcare staff on end-of-life care. The challenges that were raised by hospices as part of this work, including misconceptions of, I find often when looking at access to care in prisons, so many of these problems are reflected in sort of our wider community work as well. Misconceptions about what hospices are, what services they can provide, and how they can support their local prison. And so prisons might be less likely to reach out as a result of not quite understanding what it is that their local hospice can offer them. However, this misconception does go both ways. So often it might also be that hospice might not be aware of the realities of supporting people in prison. Another key challenge is reputational risk. So I'm sure this won't be a surprise, but being charitably funded, marketing support for people in prison is often not popular with the community. And two other key issues that kind of came out in this survey were around that point around the diversity of the needs and wishes of people at end of life, and the importance of really acknowledging and respecting those, because sometimes people in prison might not have wishes that you expect. So quite a lot of people who are dying in prison may prefer to die in prison rather than die in a hospice or die in an acute setting. So it's that emphasis on needing to respect those wishes, because they might not often be what you expect. And also the importance of risk assessments if you are having a person in prison come into your inpatient unit, because there's a lot of challenges that may arise, and so it's really important to have those discussions with the prison before that takes place. Nationally, there's also been a reaction. So in 2018, NHS England released the Dying Well in Custody Charter and Self-Assessment Tool. So that's guidance and best practice around palliative and end-of-life care in prison. In 2020, the House of Commons Justice Committee conducted an ageing prison population inquiry, and they specifically looked at palliative and end-of-life care within this. And they said this is not consistent, and that was one of the big issues that came up in that inquiry. And that's one thing that we've seen in the work that we've done, that there's these really amazing pockets of good practice, but that's not consistent across the prison estate. The Ministry of Justice is also currently working on an ageing prison population strategy, which is due to include palliative and end-of-life care. And finally, myself, Maria, Annalisa, Danny, and many others have been, Julia, my colleague who's somewhere here, have set up a new ECHO network focused on palliative and end-of-life care for England and Wales, which I'll be talking about now. So, why did we set up an ECHO? Generally in the conversations that we've had with palliative and end-of-life care professionals and people working in the prison system over the last couple of years, two key challenges have really stuck out. So one of those is a lack of knowledge or skills or prioritization by people working in prisons who don't often care for people who are dying. So there are prisons like Maria, Annalise and Danny who are really very high older populations. They'll talk about that in a minute, but they have many people in prison who are likely to die more than the average prison. So if you don't have many people dying in your care, you're less likely to prioritize training around that and make sure that your staff are equipped. The other side of that coin is kind of a lack of understanding or awareness of the prison environment by palliative care specialists working outside of secure settings. So if you're a local hospice or specialist palliative care team, you might not be aware of all the intricacies of what delivering healthcare in a prison is like and how that might affect the care you need to receive and provide. And there'll be things that you can't do that you can do in the community. So we were really keen to kind of bridge this gap, and as Hospice UK, what we would think is what's the most useful thing we can do, and it's really bringing people together to share knowledge, share learning, and build those peer support networks across the entirety of the criminal justice and health and care sector. Other reasons for an ECHO network, we held a webinar in January on this issue. We had over 250 people attend. Also, that while there are communities of practice in this area, there's one for GPs, there's one for nurses, for example, there was no community of practice that focused on both across the sector, across criminal justice, across health and care, and also included both non-clinical and clinical staff. And one of the key issues that's come up is around non-clinical staff not knowing how to support someone dying in their care in prison. So we thought it was really important that this ECHO be open to operational staff as well as clinicians. Finally, a bit of a plug. So we set up this ECHO, we've had our curriculum setting, and we're about to have our first session on the 29th of November. We set it up with HMPPS, NHS England, UK Health Security Agency, and I've put specialist palliative care professionals, but really I mean Maria and Annalisa, who are going to speak to you in a moment. It's for professionals across the health and care and criminal justice system, so it goes without saying that the likelihood is that any of you could join, and I'm sure you know people who might be interested in this who could join as well, and we're really keen to have people with as diverse perspectives as possible. The purpose of this ECHO is for members to develop their knowledge and their skill, to share best practice. So where's that really good work going on? How can that be applied in other prisons, in other hospices? to compare their experiences and share some of those challenges and have some of those difficult conversations around the issues they face within a sort of trusted community. And finally, to make those multidisciplinary connections so that, you know, someone in a prison in east of England might be able to call someone working in a hospice in the northeast who they've met through the Echo to ask them for advice. So really build those connections. So, thank you very much. Please do join the Echo or share the Echo with whoever you think might be interested. And I'm really excited to hear from Maria, Annalise and Danny now, so I think I'll just hand over to them. Thank you.
Good afternoon, everybody. So I'm Maria O'Neill. I'm the Specialist Palliative Care for the Health and Justice System for the whole of Cambridgeshire now. So I look after an A, B and C cat prison.
I'm Annalise Matthews. I'm consultant in palliative medicine, also for Cambridgeshire. So I do also have another job, which Katie introduced at the beginning, but for the purposes of this talk, Maria and I are unique in that we are employed by a prison healthcare provider to provide specialist palliative care in the prison. I'll also introduce you to Danny.
And I'm Danny Newland. I'm a custodial manager, but I'm also a family liaison officer. That's a voluntary role within the prison.
Okay. So before we start, I'll just put a brief content warning because we are talking about prisoners. As we'll get on to, Little Hay is a specialist sex offenders prison. We're not really going into their offending, but quite possibly the topic will come up. So I just want to start with an example of a typical patient for us. And if you look on the left, maybe he doesn't look so different to any other patient that you see in palliative care. But if you look on the right, you can see that we have a lot of issues that maybe are unique to prisoners. So do you want to talk a little bit about him?
So yes, he's been recently diagnosed, and part of my role, taking it upon myself, so as part of their support, if I know that somebody's going to be having bad news, a terminal diagnosis, or even just a cancer diagnosis, which is not just, then I will attend. So I work really well with the admin team. They give me the heads up and I will accompany them, because as soon as they hear that C word, it all flies out the window. So I was there when he had his first diagnosis, and automatically it was straight on to, I want my pregabalin, that I was taken off. And that's the whole topic of his conversation, not the fact that actually he still has 50-50 chance of survival even after all the chemo, the radiotherapy and the operation. In fact, this week he's off to have a stoma just to start his treatment. You have to be really careful about what you say to this young man, because he will latch on to something and then he will run with it. So he's going to be one of our most difficult characters to look after, which I work really well with the Safer Custody, so we all work as a big team.
Okay, so Danny's going to just talk a little bit about prisons, because you may be familiar with your local prison, you may be not, and just because as specialist palliative care people may not know very much about prisons, every prison in the UK is completely different from another.
So, as it says up there, the category A jail, loads of escape would be highly dangerous for the public or national security, thus necessitating maximum security conditions. You will have a lot more staff, officers detailed in that prison, a lot more secure, dogs and stuff like that. So category B, which is a lot of jails, the local jails they're called, and generally have a lot of remand prisoners there. They don't require maximum security, but if there was an escape, you've got more things in place to make it more difficult. Little Hay falls into the Cat C status. Those who cannot be trusted in open conditions but are unlikely to try to escape. And that's key when trying to place a prisoner into a hospice, to try and get them understand the security issues around what we have to deal with, as well as what protecting their staff at hospice. And then you have the open prison, which is Cat D prison. People generally go there, been risk assessed, and they can go on home leave and they get jobs in the community prior to being tested before getting released.
Yeah, and even within those categories, different prisons will have different specialities. So everyone is completely different. So Dan, do you want to tell us a little bit about HMP Little Hay?
Okay, so we do have a high number of deaths. We have 27 deaths in 2021 to 2022. Considerably higher than anywhere else in the country. We've got 1,200 prisoners. Most of them are over 50. Well, I would say 50% are over 50.
50% over 50 the last time I checked,
Yeah.
which is very unusual for a prison, that our prison skews much older. So again, when you're thinking about the prison that's local to you, how much palliative care they have will depend to a certain extent on how old the prisoners are.
Yeah, and that would also impact regard to escorts. So we have probably 8 escorts a day, just general hospital appointments, which is very staff intensive, just because of the age of our population.
Okay.
Yeah, and currently as a family liaison officer, my caseload of people who are either end of life or terminally ill is roughly about 25 at the moment.
Yeah. So are prisoners different to the general population? I was taken by Katie's list of people in inclusion needs, because actually we have all of those people in prison, so they have multiple disadvantages. We have a lot of people with learning difficulties, a lot with head injuries. We're largely talking about the male estate here, because 96% of prisoners are male, only 4% are female. In the female estate, practically everyone has had a head injury as a result of domestic abuse. We have a lot of mental health problems. We have a lot of people with personality disorders. Illiteracy is a big issue as well. How much people are actually understanding what you're telling them or what they were told at hospital. There are prisons that are designed purely to deal with foreign nationals. And then we have the travellers, veterans, and neurodiversity is a big topic in prisons at the moment. A lot of people will be diagnosed for the first time when they come into prison. And the number of people with previous experience of abuse is very, very high.
So our second patient that we've got, happily, it's looking pretty good, to be honest. Again, this is what is a normal prisoner, unfortunately, in towards our prison entails, usually from a young age as well. His anxiety levels were massive, well supported with the mental health team, with myself and Annalise and with Danny, but also the crayfish group, which I'll talk about in a moment. Very suspicious lesion he had on his bladder recently, climbing off the ceiling. It wasn't pleasant to see. However, it was really nice to know that actually everything was okay, so it's all good.
So again, it's just really difficult for this patient, you know, who is a man, very connected with his masculinity, unable to really talk about his emotions, but you can just see from his story how much emotions are an issue. So previous speakers also touched on the fact, why is prison different? You are away from your family, and when you are ill, who would normally support you? Your family. They're not allowed to go to any hospital appointments with them for security reasons. There's no exceptions to that. They're not able to access the internet. They're not able to phone up their hospital CNS to just quickly ask them a question. They're not necessarily provided with letters. So their access to actual information about what's going on is very, very dependent on the healthcare within the prison. And then they may just be moved to another prison, possibly even in the middle of their treatment, and all continuity is completely lost. So going to talk about another patient who has mesothelioma. He was very close to the end of his sentence, and his wife was completely devoted to him. In fact, she was running an Innocence Project campaign for his release, and we used to get bombarded with solicitors' letters, legal things, all asking for his stuff. And they found it very hard that she couldn't be there for him as his wife. He was also very desperate to survive to the end of his sentence because, you know, he wanted to be with her, she wanted to be with him. And that governed a lot of the decisions he made about his treatment, which were based on he wanted to get to the end. So we were very involved. Maria went to a lot of his appointments. We spoke to his wife a lot on the telephone and supporting her as well, because she just felt this was the most isolated you could be as a relative.
It was even worse and compacted because he was extremely deaf as well, wearing both hearing aids. So when he was putting his hearing aids everywhere, that he couldn't hear.
So what are the barriers to providing palliative care in prison? This is not an exclusive list, but the prison environment itself, prisons in general are not designed for delivering healthcare, and they're not designed for delivering it for older people. So, and increasingly older people are there. So people are locked behind a door, they have to go upstairs, they have to walk, they may not be able to have things that we think of as standard, like hospital beds and mattresses and oxygen. I go to another prison that I won't name who's claiming that they can't supply just-in-case meds. So there's a lot of different barriers. If you're prescribing opiates to a patient, they may be selling them, or they may be selling them because they're a victim of bullying. And when I first started, I prescribed oxycodone to someone, and he was vomiting them up after he was seen to take them and selling the vomit. So
it happens.
Yeah. We'll just talk a little bit about 24-hour healthcare, because the prison close to you may have a 24-hour healthcare unit, but even if they have it, it's more like a mental health facility. It's not a ward. And everybody in it will be locked in a cell. And overnight, that's what they will be, locked in a cell.
And unfortunately, I work in the others as well, who do have 24-hour. To be perfectly frank, I would not put any one of my palliative patients in the healthcare in a 24-hour because of the mentally poorly people, because the screaming, the shouting, the yelling that goes on 24 hours a day. There's no peace, there's no privacy, there's nothing. As are on the wing, they are cared for by their prison carers, so much nicer.
Okay, so as Maria said, people are cared for so we have somebody at the moment, we have 2 older people's wings where most of our work happens, but this gentleman doesn't want to go there because he has friends. He has a prison carer, but he sees his prison carer as a friend. But the carer has also bullied him to get him to hand him over his Oromorph. He's also on LTOT. He's got 2 plug sockets in his cell. One, obviously, for the television. That's not going to be unplugged at any cost. And then the other one alternates between LTOT and his kettle. And when he boils himself a cup of tea, he forgets to put the LTOT back in and gets confused. We have not found a solution to this problem.
No.
So, is prison different for palliative care professionals? One thing that I found is that it is a very litigious environment. This is the environment that prisoners are used to. They've all been through court cases, they've got solicitors, they've got legal aid. So it's not uncommon for you to be getting letters from their solicitor when they're not happy. The other thing is that all deaths are investigated by the PPO and the coroner to ensure that they have had equivalence of care. I'm not sure that everybody in this room would like to see the entirety of the care they provided for a patient poured over to see that every single stage met with nice guidance at every moment. But that is what we have. The other thing is we're working with prison officers. Obviously, we're always a team with Danny, but we're not always one team. Their focus is security, and they're not healthcare professionals. And some of them are very, very young, and they have no experience of anyone being ill at all. And many prisons actually don't have that many deaths, and when they do have one, they completely freak out.
Yeah. So I'm doing a lot of work at the moment with the prison officers and supporting them and providing whatever information. So as a patient comes through, then I'm literally on the wing helping the officers through all this.
Okay, overrunning. So what do we do at Little Hay? We do a lot of early identification of patients. We use the SPIT tool. We have a frailty program running as well, where we see everybody who's over the age of 80 and do a comprehensive geriatric assessment. We see all people with cancer from the point of diagnosis, whether they're curative or not, to do a cancer assessment. Maria's mentioned she's done a lot of education with staff, the officers, and the prison carers who we'll get onto. And we've also tried to adapt end-of-life tools that are used on the outside to be fit for purpose on the inside. And we also work very closely with our family liaison officer. So the prisoners themselves are really, really important in palliative care. I thought it was really exciting hearing the previous talk about training the prisoners to do their own bereavement support. There's something called a health trainer on every wing, who is like the prisoner's first point of contact if they're concerned about their health. We have the listeners who come from Samaritans, who will go and support anyone who needs to talk. We have our crayfish reps, we'll come on to, and then also a lot of the care is done by prisoners themselves, who, if somebody needs extra assistance, they will clean their cell, do their laundry, prompt to take medication. We have a really good project for people with dementia, where effectively their carer does a one-to-one with them whenever they're outside of lockup.
So my crayfish group is a cancer support group. Now this is an actual sort of 3D made out of matchsticks from one of the prisoners. That was his legacy to us. And it started off as a general conversation with a young lad whose mum had got breast cancer. He didn't know how to talk to her on the telephone, and this is how I created the crayfish group. So it's for people with cancer, known cancers, but I now have 4 reps. 2 of them are actively have cancer, and they are fantastic. Well, all 4 of them. The others have been touched by cancer in their family lives, and they are able to go on to other wings and help. They're not counsellors, but it's a peer support, and they're able to talk through to anybody. So we have a monthly meeting, nice cup of tea, and a real lovely support group that we do.
The other thing that we've been able to do is a lot of buddying up. Patients who have the same cancer diagnosis buddying with each other, and that's been fantastic. I just really want to quickly emphasise how important the carers are, and actually how important it is to the carers themselves. So this is a story of one of our carers who actually had a horrendous life. You know, he was very ill when he arrived at Little Hay. He was self-harming daily, and with support from the mental health team, it emerged how much abuse he had suffered through his childhood. He'd actually started self-harming at the age of 4. And he has found being able to care for other people, obviously a job he would never get in the outside because he wouldn't be nowhere near a DBS. It's absolutely transformative for him. So at Little Hay itself, we don't have 24-hour healthcare. The patients are able to choose, to some extent, where their PPD is, whether it's in the prison, in hospital, or our local hospice. Generally speaking, patients with no family wish to die in the prison because it is where their friends are. Patients with family usually prefer the hospice, and we do an individual assessment on each patient so to make sure that they don't have needs overnight. And being very kind of aggressive in our symptom control, that normally we are fine.
And to be honest, since 2014, since I've been there, I've had absolutely no need to use a syringe driver.
Yeah. So what could be the issues in having somebody in the hospice? Unfortunately, this was the first gentleman we had admitted to the local hospice, and it was like everything that could go wrong did go wrong. So he arrived, the hospice staff promptly Googled him. I worked at the hospice at the time, and I remember the nurse sort of saying, what shall I put on the occupation? Murderer, retired. And it was his dying wish to have pregabalin. He just went on and on and on about pregabalin. Somebody not from the prison side discussed compassionate release with him. He was never going to get it, but then he said he wanted to live with his family, at which point his family panicked, and this was really devastating for him to hear. Then, of course, the patient's brother came on a visit and threatened the nursing staff, so it was just very, very difficult. Okay. Got 2 minutes, Danny.
Okay, so we work very differently at Little Hay. As I say, we've had a lot of deaths in the last couple of years, and certainly since I've been doing this role. It's a voluntary role. I'm not allocated time. I have to fit it in around my day job. Generally, a lot of prisons are coming into line with what we do now, but generally at Little Hay, we get appointed at time by healthcare when they get diagnosed as terminal or need an extra support. Because obviously families are always the ones that feel helpless because they can't do anything for them. So that's what we do. So we liaise with family in a very early stage. If they go to hospital overnight, then we will let them know so they're not worried waiting for a phone call. We carry on that relationship with them all the way through the process. We meet the family at visits in hospital. We met someone at the hospice last week for an end-of-life visit, and they really appreciate that support. We deliver the death message, as they call it, which is we do it face-to-face, so we will go out wherever their family live in the country, at whatever time of day, just to break that message so we know that someone is going to be looking after them when we break the news to them. And then, as it says, we send finances, clear the sale, we deliver the property, and then we arrange the funeral and up to £3,000 towards the funeral.
Okay. And can I just say, because of this is a volunteer role, Danny put so many hours into this. He actually achieved his MBE this year. So.
So I just want to close by saying, what can hospices do? The first thing is get to know what your prison is like. They may have loads of palliative care, they may have hardly any. They may be really good at it, they may be rubbish. So find out how it works, what sort of prison it is, what they need. The other thing is, don't expect it to look like a hospice. We focus very much on what we can do, not what we can't do. And as a specialist palliative care person, it's very important for me to learn that most deaths are generalist. And the generalist stuff, the stuff we've talked about, the support groups, the prison carers, the day-to-day being with their friends, is far and away the most important thing.
And we're quite creative as well, aren't we?
You do have to innovate with your prescribing, but we've only got a syringe driver this year and we haven't used it yet. So you do have to innovate a bit to work around how controlled drug prescribing is going to work in your prison. You also need to prepare. You may want to work with prisoners, but does everybody else? So I do remember sitting with an HCA and she said, it is very real when you are washing the penis of someone you know is a sex offender. And that is not really an experience I, as a consultant, have. So that is, does everybody else feel the same about including people? The stigma against sex offenders is very high. In the Hospice UK study, it said that most people felt that prisoners deserved good quality palliative care. I think if you'd asked, do sex offenders deserve it, I think you might have struggled to get 2%.
And I think that's why we do what we do, because we're still so passionate years later that we do what we do.
Yeah. And finally, say, do you get paid for your work? All prison healthcare is directly commissioned by NHS England. So do actually get commissioned for it. It's not by a local ICB. And get to know the Dying Well in Custody Charter. And most importantly, join the ECHO group.
Definitely. Thank you.
Thank you.
Wow. Well, thank you for such a great presentation. I think we've got about 10 minutes for questions. So, yeah, do pop them in on Slido. I've just seen one come up around whether there's research or studies that look at transition support and the experience of people released from prison on compassionate grounds. I mean, my instinct, I'm not aware of anything, but my instinct would be that very few people are released on compassionate grounds.
Okay.
So I don't know how much research there could be in that area.
So we didn't cover compassionate release, but there is a compassionate release process that you're able to apply for when somebody's within the last 3 months of their life. I've spoken to the Ministry of Justice recently, and they've actually tightened up the criteria, so it's even more unlikely that someone will get it. So if you have experience of having a prisoner who got compassionate release before, it's even less likely that you will now.
We've had 2 in the last 5 years.
We've had 2, and they were both very close to the end of their sentences, and otherwise just because they don't just do it on health grounds, they have to have somewhere to live. They take in the victim perspective. So if you're quite early in your sentence, it's likely it would be argued that the victim was expecting you to be in longer. The nature of the offences and also what your behaviour has been like in prison. And once you put all those factors in, even for non-sex offenders, the number of people that are going to get it is going to be minuscule. A bigger issue for us is transitioning people who just naturally come to their end of their sentence and are being released.
We had one last week.
Yeah.
There's nowhere to go. Very elderly man, walks with a Zimmer frame.
Has dementia, nowhere to go. And I think he was found a hotel with hours to go before he was released.
Thanks, guys. I'm just seeing a comment that there are people having trouble submitting questions by Slido, because if so, do pop your hand up, because we have mics as well. But there are a couple that are through, but do pop your hand up if you're struggling to submit a question, because I think there might be some issues with the app. We've been asked, you, Annalisa, has been specifically asked about personality disorder subgroups and how that's been kind of quantified if there's a formal diagnosis.
So, some of our patients will already be known to mental health and they will have a personality disorder diagnosis and you will know what it is. But for the vast majority, they have not. But you get very good at picking it up. Yeah, you know, as Maria says. So we have someone at the moment, and I think the thing to bear in mind is that a lot of these people have had such trauma in their childhoods. We went to another conference where somebody had asked and he said, you learn to manipulate to stay alive. And that's a lot of what we experience. The people are very manipulative, but they don't necessarily mean to. That is, effectively, they learned in their childhood that they need to do that.
They do keep us on our toes, though.
Yes.
We've also had a question around Marianne and Suzanne's presentation, which I will pass on to them, about kind of the drop in confidence levels that was seen following training around grief and loss for people in prison. I can answer the question that it was wellbeing navigators, health and wellbeing navigators that they worked with in HMP Birmingham. Another question that's come through Slido is, do you think there's a role, place or need for palliative rehabilitation in prisons, symptom management, education, optimising function, etc.? Yes.
Definitely. Yes, definitely, because although, I mean, again, what you have in every prison will be different, but rehab is very much geared to the younger person who's had an injury or for the chronic pain, well, because chronic pain is a massive problem in prisons. it's not necessarily focused on the needs of a palliative patient or an elderly patient.
Are there any questions from the floor, just to throw it out there, that anyone has? Because if not, I'll start asking my own. I wonder if you might feel able to talk, sorry to put you on the spot, but about some of the work that you've done surrounding frailty in prison, because while that is, I think that's quite an interesting issue that's associated with the ageing prison population, that people are finding more and more that they're needing to look at how to support their prisoners with frailty.
Well, like what we mentioned, we have two specific wings, I&J wing, who are predominantly the elder population, which is, to be honest, is going to be extended simply because it's the nature of the people who are coming through. So there is more and more of that population, and because of our reputation, as it were, of being geared to more of the older gents there, then we're being targeted for more of a, it feels like a bit of a nursing home, to be honest, doesn't it? But Annalise and myself have, we're just sort of sorting through with the audit that we was doing.
So I&J already do a lot of work themselves. They've linked with another wing that does older people's coffee morning. The gym instructors have done lots of work themselves to actually work about older people's gym, rather than sort of football and weights, which is like what the younger people wanted. They're
Danny with his sensitive.
You're bringing in chair exercises. Do you want to say what you're doing, Danny?
Yeah, we have a lot of people in prison now with dementia. I think at the moment we're 17 in Little Hay, so we've created a sensory room. It's very small, but twice a week they can come over to the sensory room, just have a chill out, and then they go back, and it just gets them out of the cell, because otherwise they're just going to sit in their cell and that's it. They're not going to bother coming out.
So we did a sort of pilot of doing a comprehensive geriatric assessment. We picked the over 80s slightly at random, just because we felt that they were a defined group and we could manage the workload. We couldn't really manage the workload, but we did it anyway. We did uncover quite a lot of need just by doing that. We uncovered some really, really healthy people who were really, didn't have any diagnoses and went to the gym every day and had jobs. But we also discovered a lot of people that had multiple comorbidities, and we did a lot of advanced care planning. And we presented this quite recently, that actually that came in useful because they are a frailty population. They do go in and out of hospital. We think we reduced admissions, but when somebody went into hospital, we were able to say, we've had these conversations, we know what they want. So it was very helpful.
I've just seen a comment that mentions Marie Curie's Scotland Echo community, so I just wanted to flag that they actually held 7 sessions earlier this year, specifically Scotland focused on palliative and end-of-life care in prisons. Someone's rightfully flagged that in the comment that was also a really, really great initiative. We've had a very interesting question come through around how you support people in prison with different cultural needs in relation to death and dying. I don't know if this is one for you, Danny, or...
To be honest, we haven't really come across it. We had one, so we did it in a rather strange way. We arranged an end-of-life visit, and it was the first time it's ever been done, but we did it in cell. So we arranged for the rest of the wing to be locked up, and then the family came onto the wing. Culturally, we allowed 2 people that were of the same faith to sit in as well with them. It was all about the communication. We had the chaplain in there, the Muslim chaplain that went in there with them as well. And they spent probably about 4 or 5 hours before he passed away with that. But it's very rare that it happens. So generally, it would be ad hoc. We would make it up as we go along.
I think a lot of it is about individualisation, not personalisation, not making it up as we go along.
Yeah.
But, we've had two people that were gypsies, and we did a lot of reminiscence about, which was actually amazing for us, because they were quite elderly and told us all about
it made me cry.
yeah, their lives on the road with the horses and so on.
Born under the caravan and...
Yeah, so a lot of it is about just listening to what that individual person wants and trying to tune into their language.
Yeah.
Unfortunately, as a flurry of questions have come in, I think that's probably time, but I thought I'd just mention that there's some very kind words in the Slido, particularly saying you're inspirational, and also particular kudos to Danny on doing everything he's doing as a volunteer.
Yeah,
so, but yeah, thank you so much for coming, and I'm just so pleased to see this level of interest in this issue, so thank you, and I look forward to seeing what so many of you might go away and do next.
Thank you.
Thank you.
helps you achieve excellence online with minimal fuss and in double quick time. We're constantly updating Happy to meet the needs of charities looking to thrive, not just survive. Happy has grown from feedback from your community of not-for-profit professionals. So what does Happy do? Publish engaging content, appeals and campaigns in a drag-and-drop environment. Create infinite donation widgets and impact statements. Launch exciting events at the drop of a hat with fully customized mass event bookings. Forget mundane data admin, Happy seamlessly connects to your donor CRM. Improve retention KPIs with automated post-donation communications. Empower your charity with consent management while remaining fully compliant. Want to take your fundraising to the next level? Interested in benchmarking and comparing your fundraising KPIs? Discover the fundraising fitness test and realize your true potential. So what is the fundraising fitness test? The FFT is an invaluable tool for not-for-profit professionals, helping you implement positive change with confidence and conviction. It's the UK's leading income analysis platform, highlighting growth opportunities at the click of a button. Best of all, it's free to all UK registered charities. Interested? Book your Happy demo today to understand how to transform your charity tomorrow. Looking for innovative and exciting ways to improve income generation? Want to understand what more your website can offer? Meet Happy, the website solution for charities. Out of the box and ready to go, Happy helps you achieve excellence online with minimal fuss and in double quick time. We're constantly updating Happy to meet the needs of charities looking to thrive, not just survive. Happy has grown from feedback from your community of not-for-profit professionals. So what does Happy do? Publish engaging content, appeals and campaigns in a drag-and-drop environment. Create infinite donation widgets and impact statements. Launch exciting events at the drop of a hat with fully customized mass event bookings. Forget mundane data admin, Happy seamlessly connects to your donor CRM. Improve retention KPIs with automated post-donation communications. Empower your charity with consent management while remaining fully compliant. Want to take your fundraising to the next level? Interested in benchmarking and comparing your fundraising KPIs? Discover the fundraising fitness test and realize your true potential. So what is the fundraising fitness test? The FFT is an invaluable tool for not-for-profit professionals, helping you implement positive change with confidence and conviction. It's the UK's leading income analysis platform, highlighting growth opportunities at the click of a button. Best of all, it's free to all UK registered charities. Interested? Book your Happy demo today to understand how to transform your charity tomorrow. Looking for innovative and exciting ways to improve income generation? Want to understand what more your website can offer? Meet Happy, the website solution for charities. Out of the box and ready to go, Happy helps you achieve excellence online with minimal fuss and in double quick time. We're constantly updating Happy to meet the needs of charities looking to thrive, not just survive. Happy has grown from feedback from your community of not-for-profit professionals. So what does Happy do? Publish engaging content, appeals and campaigns in a drag-and-drop environment. Create infinite donation widgets and impact statements. Launch exciting events at the drop of a hat with fully customized mass event bookings. Forget mundane data admin, Happy seamlessly connects to your donor CRM. Improve retention KPIs with automated post-donation communications. Empower your charity with consent management while remaining fully compliant. Want to take your fundraising to the next level? Interested in benchmarking and comparing your fundraising KPIs? Discover the fundraising fitness test and realize your true potential. So what is the fundraising fitness test? The FFT is an invaluable tool for not-for-profit professionals, helping you implement positive change with confidence and conviction. It's the UK's leading income analysis platform, highlighting growth opportunities at the click of a button. Best of all, it's free to all UK registered charities. Interested? Book your Happy demo today to understand how to transform your charity tomorrow. Looking for innovative and exciting ways to improve income generation? Want to understand what more your website can offer? Meet Happy, the website solution for charities. Out of the box and ready to go, Happy helps you achieve excellence online with minimal fuss and in double quick time. We're constantly updating Happy to meet the needs of charities looking to thrive, not just survive. Happy has grown from feedback from your community of not-for-profit professionals. So what does Happy do? Publish engaging content, appeals and campaigns in a drag-and-drop environment. Create infinite donation widgets and impact statements. Launch exciting events at the drop of a hat with fully customized mass event bookings. Forget mundane data admin, Happy seamlessly connects to your donor CRM. Improve retention KPIs with automated post-donation communications. Empower your charity with consent management while remaining fully compliant. Want to take your fundraising to the next level? Interested in benchmarking and comparing your fundraising KPIs? Discover the fundraising fitness test and realize your true potential. So what is the fundraising fitness test? The FFT is an invaluable tool for not-for-profit professionals, helping you implement positive change with confidence and conviction. It's the UK's leading income analysis platform, highlighting growth opportunities at the click of a button. Best of all, it's free to all UK registered charities. Interested? Book your Happy demo today to understand how to transform your charity tomorrow. Looking for innovative and exciting ways to improve income generation? Want to understand what more your website can offer? Meet Happy, the website solution for charities. Out of the box and ready to go, Happy helps you achieve excellence online with minimal fuss and in double quick time. We're constantly updating Happy to meet the needs of charities looking to thrive, not just survive. Happy has grown from feedback from your community of not-for-profit professionals. So what does Happy do? Publish engaging content, appeals and campaigns in a drag-and-drop environment. Create infinite donation widgets and impact statements. Launch exciting events at the drop of a hat with fully customized mass event bookings. Forget mundane data admin, Happy seamlessly connects to your donor CRM. Improve retention KPIs with automated post-donation communications. Empower your charity with consent management while remaining fully compliant. Want to take your fundraising to the next level? Interested in benchmarking and comparing your fundraising KPIs? Discover the fundraising fitness test and realize your true potential. So what is the fundraising fitness test? The FFT is an invaluable tool for not-for-profit professionals, helping you implement positive change with confidence and conviction. It's the UK's leading income analysis platform, highlighting growth opportunities at the click of a button. Best of all, it's free to all UK registered charities. Interested? Book your Happy demo today to understand how to transform your charity tomorrow. Looking for innovative and exciting ways to improve income generation? Want to understand what more your website can offer? Meet Happy, the website solution for charities. Out of the box and ready to go, Happy helps you achieve excellence online with minimal fuss and in double quick time. We're constantly updating Happy to meet the needs of charities looking to thrive, not just survive. Happy has grown from feedback from your community of not-for-profit professionals. So what does Happy do? Publish engaging content, appeals and campaigns in a drag-and-drop environment. Create infinite donation widgets and impact statements. Launch exciting events at the drop of a hat with fully customized mass event bookings. Forget mundane data admin, Happy seamlessly connects to your donor CRM. Improve retention KPIs with automated post-donation communications. Empower your charity with consent management while remaining fully compliant. Want to take your fundraising to the next level? Interested in benchmarking and comparing your fundraising KPIs? Discover the Fundraising Fitness Test and realize your true potential. So what is the Fundraising Fitness Test? The FFT is an invaluable tool for not-for-profit professionals, helping you implement positive change with confidence and conviction. It's the UK's leading income analysis platform, highlighting growth opportunities at the click of a button. Best of all, it's free to all UK registered charities. Interested? Book your happy demo today to understand how to transform your charity tomorrow.
That's lovely. Ladies and gentlemen, may I please have your attention? Thank you. Director Ellis, distinguished guests, ladies and gentlemen, to formally welcome you here this evening, representing the Lord Provost of the City of Glasgow, may I introduce Baillie Margaret Morgan.
Good afternoon, everyone. It's my immense pleasure on behalf of the Lord Provost and the citizens of Glasgow to welcome you to our great city. I believe this is the first time Hospice UK has held its national conference in Glasgow. We're very glad you're here. I'm confident our citizens' world-class hospitality, warmth and sense of humour will bring you back. Everyone who works in a hospice and end-of-life care sector is special. You carry out expert, emotionally taxing and demanding work. Undoubtedly, the additional demands of the pandemic made your work even more difficult and stressful. Your frontline campaign and Just Be helpline currently going some way to lend support to affected health and emergency workers. On behalf of every single person you have cared for and the family and friends you supported, I give my gratitude. It's humbling to have this opportunity to personally thank you for your work. Tending those approaching the end of life, whether children or the elderly, is challenging and stressful. I'm sure you also acknowledge that professionally. It's a privilege and extremely important to get it right. Dignity in life and in death is what we all hope and wish for. As you know, on the front line, delivering that can be complex and nuanced. That's precisely why your conference is so valuable. For all those working in this type of care setting, I understand that Scottish-based hospices will be contributing to conference. I'm confident they'll welcome the chance to share their knowledge and perspectives. Friends, I'm sure you'll agree, the pandemic has forced us all to reevaluate how we live, personally and professionally, making us focus on what really matters. We all recognise that friendship and fun is of huge value. I can assure you that this is a city that recognises that. Glaswegians like a laugh and a joke. They're also first in the queue to help someone less fortunate. I'm proud to say we've a strong sense of social justice. This fun place is filled with humour. Seriously though, we're incredibly proud of our friendly reputation. Please enjoy your conference and the city's hospitality this evening. I wish you all a great stay and trust you leave Glasgow with fond memories. Thank you.
Thank you very much. And now, ladies and gentlemen, to reply to Baillie Morgan's civic welcome, may I introduce from Hospice UK, Jonathan Ellis.
You thank the Baillie, the Lord Provost's office and the Glasgow City Council and of course the citizens of this incredible city for hosting us this week and for their very generous hospitality and support. We're very grateful to you for your generosity and very grateful to you for generously sponsoring this evening's civic reception, which will be taking place after this session this evening. So thank you on behalf of Hospice UK, on behalf of all the delegates and on behalf of the entire hospice movement for your generosity.
Thank you.
Well, ladies and gentlemen, welcome to the final session of the first day of this amazing conference. For those of you who don't know me, my name is Jonathan Ellis and I'm Director of Policy Advocacy and Clinical Programmes at Hospice UK, and really pleased to be chairing this afternoon's session. So welcome not only to all of you who are here in the room with us, but also those who may be joining virtually via the online platform. Just a reminder that recordings of sessions will be available in about 10 days' time on the new platform, and there are details of that in your conference brochure. During this session, if you have any questions that you would like to put forward. If you're watching online on the virtual platform, then please put your questions into the question and answer box, which is directly underneath the live stream, the live feed. If you're here in the room with us this afternoon, please put your questions onto Slido. And I think we should have the details on screen in just a second of how to do that. And just a reminder, of course, to make sure that your phones are on silent so that we don't have any interruptions through this afternoon's final session. Before I hand over to our speaker for this final session, I'd like to welcome Toby back to the platform. Toby is going to announce the winner of the Michael Howard Award for Partnership Working. So Toby, over to you.
Good evening, everyone, and a very warm welcome back to the main hall to those of you in Glasgow. So we're spacing the awards out across the conference, and these awards are a special way of celebrating the contribution that some individual members of Hospice UK and your people are making, and the difference that you're making to the impact in the sector as a whole. And I would also like to say that these awards are specifically sponsored by our partnership with the National Garden Scheme, one of Hospice UK's largest funders. I'd like to take the opportunity to thank them. I know they'll have people here later in the week, and indeed last week they announced the continuation of the very substantial support that they give to us as Hospice UK. Without further ado, I'd like to announce the Michael Howard Award for Partnership Working, and the winner is St Oswald's Hospice for their combined supportive care service. And I think the award is going to be accepted by Felicity Dewhurst and Jenny Welford from the charity, so congratulations.
Thank you very much, Toby, and congratulations to St Oswald's, an amazing achievement. One of the themes throughout the conference so far, and indeed through the conversations that we've all been having over many months now, are the challenges associated with workforce pressures and the challenge that is presenting to the continued operation and expansion growth of hospice care to meet that growing population need. It's something, as Toby mentioned in his opening remarks this morning, and I know has come up in several of the sessions throughout today. Those workforce pressures are not, of course, unique and specific to the hospice sector, nor are they unique and specific just to the health and care sector. These are in many ways macroeconomic challenges that we are all navigating a path through. I'm delighted that we're joined this afternoon by Billy Palmer from the Nuffield Trust, Billy joined Nuffield in 2018 as Senior Fellow in Health Policy, having spent the previous 10 years at the National Audit Office, which is the body responsible for undertaking value for money assessments of government policy. Billy, I'm very much looking forward to hearing what you've got to say this afternoon, and I'm delighted to welcome you to the stage.
Thank you. And what a privilege. Yeah, so I lead on the Nuffield Trust. It's an independent think tank. We're effectively a charity. We're not the gym, and we're not the private hospitals. I don't get free access to either of those things. Yeah, I lead on NHS workforce issues. We do a bit of work with social care, which might make you think, why is he speaking about to Hospice UK? I think there's some cautionary tales here. I think there's some things that have some clear parallels and areas to generalise. Hopefully it's apparent as we go through. If not, we can pick up on the questions afterwards. But let's give an overview. This is as brief can be as an overview. 4 words: you need to plan, allocate, understand, retain. I mean, that's not exhaustive. But they're broadly the themes I wanted to draw out here based on the research that we've done, and I think is relevant. And to go through those, I want to introduce 4 characters that I think are kind of relevant. They might not be obvious who these are. We've got a knight, we've got an antiquarian bookkeeper, we've got an elephant, and we've got a general. So they're going to steer us through these themes. So let's start with the knight. The Right Honourable Sir Henry Willink, who's actually nearly extremely famous in terms of healthcare. Born in 1894, by 22 he had commanded a battery in the Battle of the Somme. In 1944, post World War II, following the Beveridge Report, he wrote a National Health Service, proposing a free, at the point of delivery, health service, albeit with a slight difference to the proposals that came a year later under Labour and Nye Bevan, which was publicly organised rather than publicly provided. But that was his sort of, that was his background. Some years later, in 1960, he was charged with doing something important, to do some workforce planning. Do we need more doctors? Do we need more clinicians? They thought about it hard. They decided, and there's a commission in 1955, that by 1960, we would definitely need fewer doctors. Quite a lot fewer, 12% fewer. His name, albeit not nowadays, but at the time, became a byword for disastrous planning. In some respects, it's a little unfair on him. He wasn't alone. I apologize. This is the standards of extremely difficult things to see. This is just a snapshot of a 1954 BMJ article. BMJ obviously never get things wrong. And this is one occasion they did. They suggest there were too many doctors. And in fact, 4 years before that, they were saying it's pretty reasonable to suggest we'd probably plateaued on the number of doctors we needed. Boy, were they wrong. And I think it's important about this workforce planning. In the autumn statement, one of the good gags from it, I guess, was the Chancellor Exchequer noting that in his previous role he'd recommended and sort of self-referencing himself about the need for workforce projections. These are necessary. They're not sufficient. You need to know, and you need to have some objective idea of what staff you need. Having that data alone will not get you the staff you need. And we know this from history. So let's fast forward from post-war to a decade ago. So here's a chart. We go from 2010 2012 to 2018. And what happens here is that Health Education England, charged with making sure that we were training enough staff, asked local bodies, please tell us what you think you need in the future. So let's start. I've grayed out some purple lines. We'll see them there. So the bold purple line there, that's what Trust came back, so the employers came back and said, well, you know what? We probably need about the same number of, adult nurses next year, but then we're going to have to get really efficient. So we'll probably need to cut our number of nurses the years after. Following year, sort of slightly less bold purple, they sort of realized actually we needed more last year than we thought, so we'll start our projections there, and actually maybe next year we got it wrong. We need more nurses next year. So this is in 2013. They're saying 2014, yeah, more nurses, but then we're suddenly going to get efficient and we're going to start cutting the number of nurses we need. They're nothing if not consistent, I guess, this workforce planning. 2014, they asked the same question. Oh, you know what? We got that wrong. I mean, they got it wrong by a lot, right? They were off by like 10,000 nurses within a year. I mean, that's substantial. We're going to need more next year, but then we're going to plateau. Of course, that wasn't the need. There was, the actual demand, the green bar went up, and actually, if you continue, it sort of carries on a reasonably similar trajectory, way off the scale of this chart. There's reasons for these underestimates. They were linked at the time, workforce plans were linked to fairly unrealistic efficiency, so financial targets, which were never going to be achieved, and were wholly optimistic. And as a result, they were trying to suppress the actual cost base of the services, and therefore underestimated the number of staff. But there are other reasons why we get our workforce plans wrong. The actual number of staff you need is not just about a sort of objective view of patient need, but also the cost of staff. And throughout the UK, we're even unclear really what staff are going to cost during this current year, given the pay disputes, let alone in future years. The number of staff can be trumped by manifesto commitments, which will set a different pressure on how many staff you'd need. It can be on unforeseen things like views on safe staffing. The Mid-Staffordshire inquiry precipitated some safe staffing sort of advice and a push towards filling unfilled posts. That put £250 million cost pressure on the NHS to fill those posts. It's difficult to predict. And it's also difficult to predict the supply of staff as well. Who would have known that over a couple of year period, the US were going to start recruiting tens of thousands of nurses, English-speaking nurses, who otherwise might have come to the UK a decade or so ago. Some of that uncertainty, I guess, is hospices to a degree protected from. They sort of probably less likely to be affected by top-down ministerial staffing targets, but much of the uncertainty probably still applies. And even when they get projections, they don't always use them. In 2014, we had a Centre for Workforce Intelligence that was sort of embedded within the government to advise on how many staff were needed. They said there was likely to be a 30% undersupply of old age psychiatric consultants. The following year, the number of training places for that specialty remained unchanged. Not even by a single junior doctor did they change it. So it's difficult planning, but we have to realize the cost of having too few is not the same as the cost of having too many staff. So you probably want to err on the side of caution and have too many. Are there any other tools and techniques to get workforce plans right? Most of this is a cautionary tale. There are some things that appear to make sense. A pre-mortem, let's assume you get your workforce plans wrong. Sit in a room, think, look in the future, let's say we've got them wrong. Why do we think that's happened? Really try to think about what are the factors that are likely to bias your predictions and try to think that through. And when you get them wrong, you have to rely on overseas recruitment. Little game of higher or lower here. 1 in 5 nurses qualified from outside the UK. GPs, higher or lower? Higher. 1 in 4 GPs report a nationality other than British. Hospital doctors, higher or lower? Higher. 1 in 3. Actually, the NHS as a whole is not totally out of kilter with the economy at large. About 1 in 7 across the NHS as a whole report a nationality other than British. It's about 1 in 8 across the economy as a whole. But they're very much centred on some of these clinical professions where there's a far higher proportion. Looking at nurses in particular, this is just, you don't have to look too much in the detail. This is just showing the proportion of UK versus non-UK trained nurses joining the UK register by year. And the orange and green bars is non-UK. So you can see there's been a big increase. It was pretty much half of UK joiners last year. In fact, it accounted for 90% of the net increase. Well, overseas nurses account for 90% of the net increase of nurses. And why is that important? Because overseas recruitment might work in some places, geographically, some service types, some types of providers, but is it necessarily going to work everywhere? There's a large upfront cost, maybe £10,000 to £12,000 upfront cost to bring in a nurse, for example, from overseas. But that might be difficult if you're a smaller organisation and don't have the sort of the existing infrastructure and resources to do that. I know, Toby, you wrote a recent sort of opinion piece, and the ICS has appeared 24 times in it. And I think a key litmus test here is to what extent, in England, this is specifically, but of course there's analogous sort of organisation, sort of integration type bodies and structures in the other UK nations about, the litmus test for ICS is, can they get this right to work for all services in their local areas and regions? Because we can't just assume that it will happen. And to a large extent, we need some of these overseas recruitments in the short term. Okay, the antiquarian. This is close to home to me, this one. John Anthony Westwood. Anyone know who this is? You might recognise him. There he is. Full name, John Anthony Portsmouth Football Club, Westwood. So he's from, Portsmouth Football Club, which is where I grew up. 60 Pompey-related tattoos. The club crest shaved onto his head. PFC engraved on his teeth. He's a proper fan. And he's quite famous because he has a loud bell, and he rings it throughout the whole match, which is quite a sort of impressive sporting feat to actually be able to hold that bell that time. At Portsmouth's peak, sadly some time ago, 2008, FA Cup winners playing in Europe, they decided the thing to do here was to move John Anthony, Portsmouth Football Club, Westwood, to his own stand. He moved them away from the home end, where he was the heartbeat of the 12th man at Fratton Park. Moved them to a sort of little corner of the stadium with his own, and they sort of thought that was a nice sort of ceremonial thing. But they allocated the staff and the people to the wrong place. Portsmouth's fortunes took a turn for the worse, and they found themselves in the division down soon thereafter. I know association doesn't mean causation. Was it really because of him? But let's roll with this. Are you putting the people in the right place to get the right results? Again, let's look at history. You can't change your model of care, and you won't be efficient unless you put your workforce in the right place. A good example here is the efforts to move staff care outside of hospitals. The 2006 government document, Our Health, Our Care, Our Say, set out the ambition. It wasn't entirely new, but certainly was repeated a lot thereafter, to shift a significant proportion of care outside hospitals. What do they do thereafter? Numbers of hospital consultants increased by a third over 8 years. So this time period went from 2006 to 2014. Number of GPs plateaued. I mean, number of GPs pretty much always plateaus nowadays. But this is not putting in place a workforce to deliver what you want and the changes you want. Taking a more recent example, with the 50,000 nurse commitment made by the government. So again, this is focusing on England data. There was actually a pretty large increase in nurses between the election and March 2022. I mean, the updated figures look pretty similar to this. I don't remember there being thinking when they said, well, we need 50,000 more nurses. We're going to shove a lot of them into adults. We probably need fewer learning disability nurses. We probably need fewer health visitors. That's where they've seen fall. We probably need fewer practice nurses, so nurses working in general practice. They're the sort of the orange bars that have actually seen declines over that period. In fact, over a 10-year period, we've seen 24% increase in adult nurses, a 2/3 increase in children's nurses, but 10% falls in community health, 43% in learning disabilities, fall in mental health nurses, fall in health visitors over that longer 12-year time period. It's again about how we make sure we can attract staff to the settings where they're needed and not just be working off this large sort of aggregate figure. We're doing okay because we've got 20,000 more nurses. But is that working for everywhere? Another quiz question. Okay, we've got 4 lines here, tracking from 2013 to currently. They are, in no particular order, 2 relating to social care, care homes, and domiciliary care. 2 relating to the NHS, hospital and general practice. You've got to think through what the order is. And it's this. Might be surprised that. The giveaway is the social care ones took a big hit around the pandemic, and certainly mid-pandemic. Vaccine policies didn't pan out too well there. So you had a very large increase in domiciliary care staff up to about 2020, and then a big decrease. Care homes plateaued. General practice, a massive increase. But again, it's a question, are we getting the right staff in here? There's been a big push for a broader skill mix, which makes a lot of sense, but do we know that general practice is able to onboard this huge influx of new staff types for them and to use them effectively and to make sure they're supported and have the opportunities and training that they need? I mean, I haven't seen 27% more output in general practice, but I wouldn't push against them saying that they feel like they're working flat out. So is there an allocation issue going on here? Are we putting the right staff in the right areas? And this one almost actually bridges to my next character. It's a movement between sexes. I apologise for some small writing on this. This is where NHS nurses are recruited from, and I guess this is pretty relevant to the hospice sector about the sort of transfer between sectors. It's a huge number going in and out between the NHS and the private sector. That's on the purple section of that donut, which is about a quarter, over a fifth anyway. And also a huge amount moving between the public sector as well, 8%, that's sort of that. I'm not entirely sure what the colour is, sort of lightish, reddish colour towards the top. And we have to be very conscious about staff moving between sectors and don't get involved in a zero-sum game where we rob Peter to pay Paul. An example here is clinical pharmacists. Again, it makes a lot of sense to have a policy to move more clinical pharmacists into general practice. They sought to have 4,500 more of them, but where did they come from? You know, you were just taking them out of existing community services, out of the NHS, and it made some of those services less sustainable. So there just needs to be a better understanding of how people move between sectors. Okay, character 3. I mean, in some respects, this is I'm a bit nervous about making anything even slightly related to wars in here, but hopefully, the fact this is Blackadder, hopefully that means I can get away with it. So General Sir Anthony Cecil Montgomery Melchett, he's constantly trying to lift the morale of his men, rather lamely, with Charlie Chaplin films, putting on a drag act, completely ignorant of their spirits, with no concept of his soldiers' well-being, and is shown to have little or no compassion. But what does motivate, attract, retain, and recruit staff? Do we have a good idea of what motivates the people who work in our services? I went to an actually excellent presentation earlier this afternoon, and I think it's Paul Knott, his name, talking about what really matters and really focusing on it. And he sort of mentioned if you're in job adverts, focus on things like parental leave, pensions, that's what people look at. I think that's true. I think some of the small things matter too, actually. I would push back a bit on that. And I certainly would, in terms of what people value, play to our understanding of behavioral psychology. People hate losing things. And we learned during COVID, some of the little perks helped. How people felt they were valued, they helped. It's not useful at all to take those away. You get like a double loss in that. I think there's also a lesson here that valuing, people derive their value by looking at how they compare to others. It's sort of a relative assessment. And in the UK, it's tricky because we have huge pay differentials. Across 26 countries with comparable data, we're second only to Korea in our disparity between nurse and senior doctor pay, and considerably above the average on that. So there's a pay thing, and there's also conditions. We looked through, for one of our pieces of work, hundreds of job adverts to see how people were trying to sell types of jobs. That was particularly focused on clinical support staff. It was very much, all of the asks were of the person applying for the job. In one case, they were even asking them to pay for some of the certification they would need for the job, demanding flexibility from day one. You compare that and contrast it to a typical NHS consultant job advert, where the entire opposite is true. They will sell it on the point of access to training and flexibility from day one. And so I think on that valuing thing, I think we need to be very careful about, given the inevitable fact that we have these sort of multidisciplinary teams and different professions in it, that we are treating people fairly. Again, sorry if it's a bit small, particularly towards the back. But I will talk you through some of the numbers, so don't worry if you can't see them particularly. This is data on why people leave their roles in the NHS. The biggest reason is unknown, which is not great. I mean, this is data that's set up. I mean, you should be doing an exit interview, and if you can't fill in a single reason, that's putting you at a bit of a disadvantage. And just now there was a presentation on data, and it was a packed room because I guess either you already care about data, or otherwise you're already nervous that you need to know a little bit more about data. But there's a lot of people who went in there wanting to listen about data and recognizing the importance of data. And maybe this is where the hospice sector can sort of get ahead of the game here. Use your agility to outperform the NHS and understanding where people join from, why they join, where people leave and why they leave. There's some interesting other things going on with this data, which I suspect you can generalize to your workforce as well. Work-life balance is pretty much the same as retirement in the latest set of data. It used to be a quarter. of retirement. So it's a hugely more important issue. When you try to unpick what work-life balance is, there's some, I guess, some slightly sort of harder reasons behind that, about people feeling exhausted, under too much pressure. That's when separately, there's a survey of why nurses leave the register. Issues like that seem to pop out. There's a purple bar in there, which is, sorry, not very well labelled, which is, I mean, fairly small in absolute numbers, but it's health. And that's increased fourfold in recent years as a proportion of why people leave. And actually, there was some interesting analysis published last month about the likelihood of clinical support staff and of nurses leaving their job within a few months of having either some absence due to physical illness or for mental health reasons, which is concerning. I mean, the only positive you can take from that is that it's clear how you would do an intervention. You know when someone's been off, so you know what the trigger point is to try to address that, to make sure that there isn't some preventable attrition and retention issues going on. Feeling undervalued is one of the key reasons why people leave the nursing register. I think we should have mentioned about how do you go about valuing people. Low staffing levels is another reason why people, that's when you ask people why they're thinking of leaving, low staffing levels. If you haven't got enough staff, at least give people confidence that the cavalry is coming, that there is a plan to address it. Some of the other reasons about retention that we find in our research, feeling engaged with the organisation, that appears to be pretty strongly associated with better retention issues. Social care. I mean, it's even more limited, the information on social care leavers. But they did survey different providers, 9,000 adult social care settings, and asked them what their top reasons for leaving, for their staff leaving were. The ones I've just highlighted in red, again, you don't have to read the specific numbers, they're about better pay. I mean, it's a different sector, social care. You expect different reasons to the NHS. And the ones highlighted in green, they're about working conditions, both with, they're leaving because of better conditions in other providers or outside of social care. Separately, the work we've done there, burnout stress is very important, is a reason for leaving. As I say, issues around pay and progression. And there's some exploratory analysis which is really quite interesting, which points to this whole professionalisation piece. And I know there was a talk earlier about how you offer people career progression, the use of things like advanced practice in nursing and other professions, use of credentialing to give people some sort of career pathway. I recognise it's early. Well, in some ways, it's not early days on those, but it's a developing area. There's question marks over the extent to which there needs to be some regulation on that. Currently, it's putting a lot of pressure and responsibility on providers, and to what extent can nationally some of that responsibility be taken up. But just on that professionalisation piece, lack of a relevant social care qualification was pretty strongly related to people leaving the care service. Less access to training, again, a key reason why people might leave. Actually, the second reason at the time why people left was did not wish to be vaccinated. That speaks to the time when this survey was done, when they were bringing in the vaccination rules. One thing I would say on that is when we looked at the impact assessment on vaccinations, the numbers didn't even add up. I mean, here's a lesson here. If you're going to bring in a policy which is going to affect your workforce, make your numbers add up and do your due diligence before you implement it. I sort of mentioned about what people value, and partly it's about understanding people's motivation, why they might join. And we did quite a bit of work looking particularly at the non-medical workforce about why people choose to pursue careers, sort of clinical careers. Typically, it's not about pay. That's not very high up there. typically it's about sort of the exposure people have had. I think it's important to be quite conscious of that people will be taking, whether it's, for them personally or seeing how relatives or people a few degrees of separation away from them are cared for, will affect their career decisions. And even things like exposure at school. So, at careers events, do people actually know what the sector is and what the types of jobs are? That does seem to have a very material effect on it. But really, I mean, that chart in itself, that's all that's showing is there's a huge attrition during training. For every 10 nurses that 10 nurse training posts, you get about 6 full-time equivalent joiners to the NHS, and we don't really have a good understanding where the rest of them go. To what extent is it sectors like hospice care or other services? It's just this need to have a better understanding of what is motivating people, and let's not just use pay as a proxy. I mean, pay is important. I mean, particularly in the current context, but it is a very crude proxy and measure for valuing people. Okay, final character. This might not be obvious. I hope I hope you can see an elephant within that. So the parable of the blind man and the elephant. I mean, there's different versions of this, but the story of a group of blind men who have never come across an elephant before and learn and imagine what an elephant is by touching it. Some might get the tusks, some the legs, some the tail, some seem to have jumped on the back. And in various versions of this, they sort of share their stories. And sometimes they come to blows because they just cannot believe what the other person's telling them. And they find it quite upsetting. And so trouble breaks out. And I guess the story from the parable is about be cautious of limited subjective experience and make sure you have a full understanding of what's going on. And to get a good understanding of the workforce challenge, a single tusk won't do. What is the workforce shortage? I mean, I don't know. And whenever someone says, in the NHS, for example, that it's 100,000, they actually don't know. There's a number that we need, that's subjective. There's a number of funded post-UU establishment. There's a number of those posts that are actively being recruited for. Sometimes you won't actually be sort of actively trying to recruit for your funded posts because you don't think you're going to fill them. Then there's some that are filled, and then there's some that's filled permanently. The most commonly cited figure on the NHS shortage, for example, covers a bit of that. Probably we want to know a different measure altogether. I mean, we tried to work it out even for a snapshot day. We think once you account for, and also when people talk about shortfalls, they're not mentioning about what's the gap actually in the rota on that given day. Is a patient or someone receiving care, I'm bothered about whether there's someone available to provide it to me, whether it's because of a vacancy or whether it's because of sickness or another reason for absence. And none of this, when people talk about vacancies, that's all too often left out. We think for nurses on a given day it might be about 17,000, something like that. But it's pretty finger of the air stuff to even get close to it. When we talk about having a full understanding of the workforce, again, often we just talk about those permanently employed. £1 in every 5 in the NHS is spent on either temporary staff or outsourced staff. If you don't understand those and understand their conditions and understand their motivation, you haven't got a good understanding of the workforce. And if you don't have a good understanding of the workforce, you make mistakes. So here's a final cautionary tale to end with. And this is using contractual changes. Again, this is a little bit England focused, although some of these contracts were used in the other nations as well. Clinical grading brought in 1988. They didn't really understand what people did or how best to reflect their grades. You had after they brought it in, you had 100,000 people contesting what pay level they were put on. Fast forward to 2003, a new NHS consultant contract brought in. They underestimated workload considerably and therefore didn't get the capacity at all right or costs right. Same when they looked at when they changed the main GP contract, the GMS contract. They misunderstood what GPs did and what incentivized them, and it cost them £2 billion for making that mistake. And then Agenda for Change contract covering the majority of NHS staff. They didn't even really confer what they were trying to achieve with that contract, let alone try to get the results they needed from it. So there we go. 4 characters, 4 or possibly more cautionary tales. Yeah, I hope there's some clear parallels with the more specific workforce you have, but maybe we can pick those up in the questions.
Thank you very much, Billy. I think those cautionary tales will resonate very strongly and powerfully with many of the people in this room. And as you say, the relationship, I think there is a huge amount to learn from the challenges and pressures that are facing the NHS in isolation. The hospice sector obviously has a symbiotic relationship with the NHS. The flow of staff back and forth across the 2 different sectors is very significant. I'm going to come to a few questions, but just to kick off, I was struck particularly by your comment around the dangers of limited subjective experience as the basis for making sort of decisions. And I wonder whether you are optimistic about the potential of, certainly within England, the new approach to integration, to system-level planning, and whether you see that as a potential path to thinking about some of these more strategic workforce challenges that the system as a whole is facing.
Am I optimistic? I mean, is this working? I guess the question probably should be really to the audience. To what extent do you feel integration is working for you and your voice is being heard across all those different bodies? And if not, then we're not in a very optimistic scenario. I mean, every time we engage in these sort of integration style policies and speak to people who are trying to implement it, there's an awful amount of goodwill and effort that goes into it. But I remain pretty concerned unless there's clear governance. Are we really aligning the funding, the responsibilities and the accountabilities correctly? Because if not, when push comes to shove, you probably won't get the results you need. And I know, taking the England example about ICSs, they're still ironing those out to some extent. So I hope that that's taken seriously, because unless you get that governance right at a national level within the legislation or the guidance around it, then all you end up having is a lot of local conversations trying to work it out themselves, and that's not very helpful. That's not, the positive drive that we need. So, I mean, there's goodwill out there. I mean, it's bringing people together in the room. I remain concerned that the governance isn't supporting the right decisions at the end of it.
Thank you.
I mean, I want to be more optimistic. But
Thank you very much for that. I'm going to come to a question from Mark Jarman-Howe, who points out the fact that the acute sector is such a sponge, is such a draw in terms of resource and staffing. And those finite resources are very much needed in the community. And Mark's question is should hospices as a sector really be targeting NHS staff to leverage our relative benefits to address the workforce pressures that hospices are facing, and to then force, in a way, the realignment of resources that is needed anyway? Just wonder what your thoughts are on that.
Yeah. Yeah, I guess the characterisation of them as a sponge. I mean, if you look at the numbers, that's where you've had these big increases in staff, and they're only going to be demanding more given the elective backlog, for example, which slightly pushes against the policy ambitions to move things out of hospitals. So, I mean, what can you do here? You have to compete, be more agile, and maybe help the NHS move forward, have a better understanding of why people are joining and where they join from, have a better understanding when people are leaving, why they're leaving, because the NHS doesn't have a great understanding of that. I mean, some local trusts certainly do, but that sort of national policy picture, they certainly don't, and others seem to be struggling. So, I mean, yeah, so, you know, to some degree, there's a finite set of resources. It is a bit of a zero-sum game at the moment. I mean, unless that issue of, like, can you get that regional and local level of collaboration to work, to get things like international recruitment working, to get a more, I guess, try to recruit from a larger pool of people, getting things like the apprenticeship schemes to work, which are really tough because, I mean, depending on the apprenticeship scheme being used, it can be financially not a great option compared to other ways of putting new staff in. But these are all things that, you know, potentially with some national, regional, and local intervention, it could work to actually, I almost said make the pie bigger, but I recognise that's a loaded turn of phrase nowadays, but to actually grow the size of the workforce.
Thank you very much. We're going to come to a question from Sonia O'Leary, who asks whether the fact that so many people who apply to do their nurse training and don't get a place demonstrate that we don't have the right resources in place, or indeed the right approach to training in order to equip our workforce for the future.
Yeah, it's been pushed forward as an idea. There was, I think it was in the NHS long-term plan. They sort of made this point that there's a lot of people applying who don't get a place. Therefore, if you just open up to more places, I'd be a little bit cautious about the implication that anyone who applying, and I know the person who's written this is not saying that, but I'm nervous about the implication that anyone applying could just, you know, should be accepted. I mean, there are requirements and capabilities that you're looking for someone training to be a nurse and all these other clinical professions. I mean, certainly there are some bottlenecks that are stopping us training more. In large places of the country, there are not all the routes available in for nursing, and in particular when you start looking at the different fields of nursing, so learning disability, mental health nursing, you don't always have postgraduate routes available. Certainly the apprenticeship one is, you know, pretty early stage of that development. So we could be doing more to improve access to those training courses and therefore get more coming through the domestic supply. But also you've got to make sure when people have a good experience when they're training, so they want to join the service afterwards. We're losing way too many, and we've just we're going to publish some work maybe in a month or two's time about this, about what you can do about this attrition during training, because it's frightening, the numbers, particularly actually for doctors, because it's expensive to train for the individual themselves and for the public purse, and even for the providers who are putting on clinical placements. And if you're not getting that right and getting people through, then, you know, that's a big waste. But if you get it right, you potentially see an instant result. A lot of people say, you know, oh, but it takes, 15 years to train a consultant. Well, actually, there's some who'll be finishing their medical training next year, make sure they have a good experience, so then they join the service thereafter. It's an instant reaction if you get that right. Did I answer the question at all then?
Yep, thank you very much. Got time for one final question, and you noted how important it is to be cautious around pay as a driver, but inevitably coming to a question around pay from David Houston, and he asked whether you could expand on your views on NHS terms and conditions, including how that package compares to other Western countries, and whether you have any reflections on what you think is likely to happen with the current pay dispute, and then, by extension, the potential implications for this sector as well.
Yeah, I think, why did I say pay? Okay, well done for picking me up on that. I think whilst I've been at this conference, we've actually, as an organisation, we've just published something just as a bit of an explainer on the whole pay arguments at the moment, because it's tricky, because you're hearing a lot from different organisations who have some skin in the game. What we have said is the current pay process setting process is not a good one. I mean, it's clear route for improvement. The fact that they are just passive recipients of evidence rather than actively commissioning research that will try to answer some of these questions about what is, you know, what will affect people's, what will affect retention, recruitment. There's also an issue in terms of the fact that you have different pay setting bodies for consultants and some of the other medical groups, and for Agenda for Change. So they have this argument that, oh, but if we increase Agenda for Change's pay bill by an extra 1%, that would be $500 million, therefore it's not affordable. So, well, but if you split those all up into separate professions, then suddenly it would look affordable to do it. So it's kind of, it makes really no sense, and that's not a fair argument. So I think there's an issue about that process. I think when you, I mean, it's difficult to talk about pay given the current rates of inflation, which make any pay deal still, you know, a massive real terms cut. But pre the inflationary issues, one of the key problems was around pay progression. So there's been various analysis around this, looking at how getting different clinical professions affect your career earnings at 1 year, 5 years, 10 years. And it's when you get that later stages, and suddenly nursing, for example, really falls behind. So there needs to be some better efforts to support progression. The current pay deal, I mean, they did the most, they recognise that you've got lots of experienced nurses sitting at the top of their pay band. And so he said, well, rather than giving this £1,400, we'll give them 4%. So I was like, well, is that much different? So we worked it out and we deducted off what tax would be. And so for those sitting at the top of band 6, that's worth 43p a day. I mean, that doesn't even buy you a Mars bar. I mean, if they think that's really going to change the behaviours of these very valuable, experienced clinicians, then I just think they're mistaken. So they need to think a bit more clearly about that progression aspect, and they need to think about, and I sort of said it before, about the relative pay point. We're increasingly getting people to work in these multidisciplinary teams. We're having people share, patient lists even, and you can't expect people to do that and be happy walking home when they know they're having to work a 5-day week to earn as much as someone working 1.5 days, which can be some of the differentials you're getting between different clinical professions. So there's some real issues with that. I mean, also you've got to make sure it's affordable. You've got to make sure it's affordable not only for the providers in the NHS, but there's also an implication for all those employing similar staff, or potentially what would be the same staff in other sectors. I mean, that has a huge sort of cost implication, and I'm not sure that's always thought through from the deliberations I see it now in that pay process.
I think that's a point that will resonate very strongly with delegates in the room. So we are out of time for this session, but Billy, thank you so much for sharing your thoughts and your reflections. I think, as you say, some very significant cautionary tales for us as we navigate a path forward into this brave new world of integration, collaboration, system-level working, which of course requires integration, collaboration, system-level working, and thinking in terms of workforce planning as well, which I think at this point has been in relative short supply. But Billy, thank you so much. Can we thank Billy for his time. That brings us to the end of the formal part of today's proceedings, but I do hope that you will join us in Hall 2 for the Lord Provost's hosted civic reception, and look forward to seeing you there.